giving me an opportunity to moderate your session. And it's always been a pleasure being Neeraj sir's student. And if you look at his specialities and his achievements, I mean, there would even these 2 hours would go off in just explaining that to you. But then the best thing about him is, as a teacher, the unique thing about him as a teacher is that I have been to many trainers, and what is unique in him is he tells you that there is what problems you can face while performing the procedures, but he also makes it a point to tell you how to come out of it. So that is the USP. Other trainers will tell you, okay, you may face these problems and you should not do it. But then he says that you should do it. These are the problems that you're going to face, and this is the way you have to come out of it. So once you finish this training, you feel doubly confident about starting any procedure by yourself. And he is, expert in, while doing the procedures, you would see how expert his needle goes. It's, something like, Messi dribbling with the football. It's as lucid and as beautiful as that. So, I mean, without any further descriptions, I would ask Shantananda to, at least validate my claims about Neeraj sir, what I have said.
Yeah, Ashish,
Good and your own work, so I'm happy to see you people around. You're doing such a great work, and you carried the whole thing in a very beautiful way. And sometimes students we have become masters, they're better than the masters, so I'm happy on that account. Very good.
I will not take much time because Ashish has told the maximum things. Same thing I wanted to tell, a little bit senior to Ashish, because I have seen first, I attended sir's workshop in 2012.
First one.
First one. Okay, so lot of things I have seen, I've learned from him, which is not there in the book, that I can tell you. Because people can read the books, people can go through the different workshops there, which is very, very common, very standard. But a lot of things are there which is unique, which is, we can say he is a scientist. He's having his own work. And that helped me a lot. What Ashish was telling very nicely, because when you are in trouble, that time, a lot of things, what Sat told, what Sat shown, that helps a lot, because that things are not there in book. Out of the book, a lot of things he invented is unimaginable. Okay, the way he describes you, unless you go through his workshop, you will miss that, and that helps him a lot of times, because everywhere anatomy is so different in every patient. So that works tremendously when anatomy doesn't support with you, situations doesn't support with you. So that time SARS techniques are marvelous. That much enough. I think we should start. People are all waiting. We should not. Everybody knows, and Dr. Neeraj Jain name is enough. We don't have to say anything about that. Okay, we can start, sir.
Thank you, my dear friends. Dr. Shantanu, who attended my first one, and Dr. Ashish, who attended later, but is really very fast. I'm happy for you and all others who have been through the.
Even I have once I have completed my FIPP in 2011.
Yeah.
So then when I was going for his workshop, some people have told me, "Hey, you have already completed FIPP, so already you have given that kind of exam. But again, why you are going to SATS workshop?" I'm like, I have not learned anything from FIPP. I've just given an exam only. Okay, but what I learned after 7 days when his workshop completed, that time I think that is there in SATS website. I expressed everything, because people used to know him for vertebroplasty till that time. Vertebroplasty all over India, only one person, Dr. Neeraj Jain. But that time I told people didn't know what his skill in other things.
So we try to
That
give
I expressed.
session practical training for all possible things which is there to do with pain. See, pain is a pain. We try to maximize. So thank you, my friends. I think it's very important. See, when you have Indians are very good in their skills. Be it world over, go globally, and you ask which is the best doctor in USA or Canada or UK for the matter, is Indian doctor. So we have so much of skill there, and we have so much praise there. Why can't we do some good work here and be praised world over? So let's do it this way, and this one of the webinar is in line of that, and we have a skill work going on, and I think I want it to be displayed and let people know about it. So this presentation has got lots of practical slides and less of theory. So we are going to go a practical way for interventional pain management, what best we can do for the patient. Ultimately, the aim and main goal is to have a pain-free patient at the end of the day, end of the procedure, and that's the whole intent. But it doesn't come easy. It takes a lot of knowledge, a lot of skills, and a lot of work. You have to do it, manage it. So I'll start with my presentations, my friends, and let's see. And we have it's about 2 hours total session. We'll have a break about 2-3 minutes, which is a commercial kind of break from the company point of view, and it'll give me break too, and then we'll restart, and then we'll finish, and we have a QA session at the end of it. Throughout the whole presentation, everybody will be on mute. Please understand this from the company side, and you're going to be asking your questions in the QA session or in the chat or in QA session, and that all questions are going to be answered simultaneously by Dr. Shantanu and Dr. Ashish. If any questions are more important, then they can be asked at the end of the session once my talk is over, and they can ask the questions to me. The moderators can ask questions, and I'll answer your questions. And if feasible, I'll put you also on the talk mode if possible. We'll see from the company side if possible, because they're going to be a big, huge number of delegates or audiences. So we'll start from my presentation, and that's how it is. I'm going to share my screen, my friends. Somebody else's screen is on share, or my screen is on share? Somebody else screen is on share, my dear?
No, sir. No, sir. Nobody has shared it.
Nobody has shared it? Okay, let me see. Okay, now, fine, I'll get you. Yes, friends, good morning on this Sunday morning, and let's make most of it. Thanks to the corona, it has given us an opportunity to have the online training and virtual learning and training and meeting friends virtually. And this is what it is, and it has culminated to this kind of a nice session on interventional pain management. And today we're going to talk mainly about the radiology, or the practical part of it, or you can say you are inside my OT, in other words, and we are not doing much of theoretical work. That's how it is going to be. So this is, we know that there is an issue. Now this is sciatica differential diagnosis and targeting interventions. We're going to talk about the 3-4 sections, by the way. This is going to be the lower back pain. Then we're going to talk about the neck pain. Then we're going to talk about neuroplasties. Then we're going to talk about the spinal cord stimulators. And then at the end of it, we're going to talk about vertebroplasty if the time permits. This all is there in this presentation. See how much ground we can cover today. Knowing that the age is becoming a very big issue, especially the older age geriatric population. With the increasing expectancy, we are having more and more older people coming in the main population group, and obviously when people age, they have problems. And what is the main problem is, the pain is one of the main or commonest problems they go through. So we have to manage. Don't take it as an age issue. Take it as a disease issue and treat as much you can. So we can maximize. We want to have one life to live. Let's maximize. Let's live pain free. That's the whole motto, and we try to maximize. The another reason why we are going through all this is the evolution, you can say, what is going on with the tech revolution, evolution, and lifestyle disease. You can say pain is mainly a lifestyle disease to begin with, and it has come. Earlier people used to do a lot of hard work, labor, manual labor, which has really gone out. And what manual labor we are doing these days is this. And you can understand it is most of it on the neck, back of the neck, which is having a toll on it, and that is what is causing problem. And we know all this. You see, our kids, my own sons and everybody, almost 20-30% of the working population are doing this day in, day out. And there's a fallout. There has to be fallout. There has to be a problem coming along with this new posture, new things coming. See, this is the evolution. What is the evolution is, we have become from 4-legged to 2-legged. Now again, we are getting into this kind of scenarios. And this evolution, because of the technology coming very, very fast, in 1 or 2 generations, our evolution is not able to catch up. That's why we are getting into all these problems of the to do with the table job or desk job or computer jobs. And you see, this is a new foe which has come in, is the mobile, and then over mobile we have all this WhatsApp every day. It's about, they say, on an average 3 hours every day you're doing mobile work, and obviously, and we are not conscious of the fact that you are not going to keep a mobile just like this, keep in front of you and do it, which is the problem. Now, when we come to the back pain, what worries us, this is the herniated disc, the spinal stenosis, or lateral canal stenosis for the matter, inflammatory spinal arthropathies, the ankylosing is one of them, and others are also there. Spinal infection in India, tuberculosis is a very, very common problem. Vertebral fractures, and instead of fractures, I will say a lot of people have a gross or severe osteoporosis. They also have a pain coming. Then we have the cancer thing, and then Kodak Vanna syndrome because of the many reasons. They will come to that, and then the referred pains from the viscera. What are the red flags we should not miss? This is a fever, weight loss. We're looking for either tuberculosis or infection, or maybe a cancer sometime. Intractable pain not improving more than 4 to 6 weeks with all conservative management. This is the time you should go for a higher modality of intervention, see a pain specialist or a spine surgeon for the matter. Nocturnal pain or increasing pain in severity, don't neglect it. This can be very nasty. People come a little late in that case, either it may be tuberculosis or CA. Don't make it too late. And then you have a morning stiffness. Obviously, we're talking about spinal arthropathies or arthritis for the matter. And neurological deficits, if at all some people have it, this is a very bad thing to happen, because then the recovery becomes very poor and late. Yes, you can manage with the medicines as much you can, but people should not do a home medication or self-medication. That's the worst thing they do with themselves, and which is bad. And there are a lot of medication issues are there, because nephropathies, I've seen higher of the dialysis units are full with the analgesic nephropathies. And with the increasing diabetic population, all the more reason that we should not take chances with your kidneys. Now, this is where we say the earlier surgery used to be the mainstay. Now, spinal injections or interventions have become one of the important treatment, a step before we do all the higher procedures. And I would say, instead of again step up, I would say step down. Higher procedures are kind of step down, not step up. It's going down the scale as far as procedures are concerned. What all interventions I'm going to talk today is the epidural steroid injection, all kind of epidurals, at the epidurogram, epidurolysis. We're going to talk neuroplasties and all. Nerve root sleeve injections, probiotic discographies to some extent, ozone or other discolysis, decompress and needle procedures. I'm going to talk about endoscopy, diseffects and other procedures. The nucleoplasties of one or the other kind, transmural or caudal neuroplasties, and I have a balloon neuroplasty in mind. We're going to talk about FACET joint SI, very, very important thing. Denervations we're going to talk about. In advanced procedure, we have a good amount of slides on vertebroplasty and kyphoplasty, very, very good slides. We'll see if we can cover today or maybe another day. RF denervations, we're going to talk sympathectomies to some extent, pumps, implants, neuromodulations, matter, Botox, and I told you about, we're going to talk about the endoscopic disectomies and diseffects procedures. Very important slide, a little pick from one of my friends' presentation. This is, by the way, they say the complication triangle. You see, the first is the prevent the complication. That's the best thing. This session is meant for that. That's what she was telling. When I talk anything, any procedure, if I say epidural, when I say epidural, I tell more about, it's like when you want to drive a car, you should know how to put a brake first before you put a speed paddle on. So the whole idea is you should know where it can go wrong and how to handle it. So that is normally not taught. This is something very important. Recognize the complication. If something has gone wrong, recognize it and treat it. You shouldn't leave here. We have had our own share of complications and we have managed them successfully. That's where what we are now. If you don't manage a complication, one bad complication will kill your career. So be clear on this, and you should have courage and knowledge and skill and help at hand to manage those complications. That's very, very important. It is bound to happen. It is bound to happen. Who says if I have not had complication, that means somebody is not doing the good work on. And yes, you need not feel sorry. If you are adequately trained, if you know your skills, if you know your job well, you can really do a good job. Now let's do the main presentation. This is about, we keep seeing all this. This is a normal disc thing. And what we see is a normal nucleus and the annulus which is there. Nice good annulus, and this is the spinal cord and the roots going up and face nice, good and clean. Look at this. This has become all kind of a blackish thing. This is a degenerative disc, and you see there is a small kind of the nucleus trying to come out of the annulus. So it's an inner annular disruption is going on. Although there is only a bulge, you see it's a concave disc, there is only a bulge inner, but it will go further on. Last few fibers are gone, say the 7 layer of fibers, last few fibers, and by the way the nerves are in last 2-3 layer of fibers. Initially there are no nerves, it's all one nature's phenomena, and these when the disc comes out and then becomes a more pathological. Remember, the disc is painful when it is internally disrupting or annular disruption is going on. There's a back pain. People will have history of back pain for years together. But once the disc ruptures and suddenly presses on the neural structure, then it becomes a leg pain. So there'll be a history that I have had back pain for some months and years, and suddenly this morning I bent for brushing my teeth and I have a leg pain, or I lifted something, I have a leg pain. That means the history was so clear. Next is go for an investigation and go for treatment. This is how it looks like. Pathophysiologically speaking, the annular, the nuclear material is tearing through the annulus because of loading or degeneration or posture. Posture is a very, very bad thing. People are not talking about posture. It's very, very important. You should talk about posture to all your patients. Correct the posture, make a natural S-shaped posture in the spine. Don't make a C posture, which normally people couch slouch, people do it. Avoid that, or boss chair for that matter. That's a bad thing, and it keeps tearing through. And I told you the nerve fibers are in the outer layer, like I told you. Nerve fibers are, and by the way, when there's annular tear going on, there's inflammation, there's a new vascularization, there's new nerve ingrowth or irritation going on, and that is what is. Now it can cause a back pain in its own right, or it can spill onto the root which is there, and it causes leg pain. Now there leg pain because of two reasons. One is a compressive one. If it is bulge and compressing, that's a mechanical compression. Or there is a physiological compromise because there is a leaking of the nuclear material, which is highly acidic and very irritating to the root DRG, and it's got a very big irritation. It's something like a salt or spice has gone into eye and it becomes irritated even if you wash it. So that's how bad it is for the root, and it causes. By the way, sometimes even when we correct the whole problem, still there is a memory on the ventral root or DRG which causes the problem. We should be very aware of this fact. Now, this is a very, very important slide. This is where we talk about nucleus, the annulus. Now, this is sinovertebral one nerve, which is a recurrent nerve coming from the dorsal branch, and it is supplying the PLL and the posterior structure annulus, and it's very, very sensitive for the pain. That is nature's protection, by the way. Nature wants to tell, okay, you are tearing open your annulus now, and your nucleus will come out, so stop. And that's where you take rest and take treatment and become fine or physio for that matter. But remember that the anterior disc is mostly supplied by the sympathetic fibers. Now this is what is called a sympathetic play is going on. That's why there's a diffuse pain. It's not a very constricted dermatomal pain, diffuse pain which is there in the back sometime, because it is mediated through the sympathetic sign. That is why sometimes we try to do a sympatholysis for the same reason, or we do a rami complicantis RF for the same reason. Yes, there is a technical problem because your spinal artery is coming just at the same level where the rami complicantis are there, so that becomes a little tricky. So one has to be aware of this fact there when you're trying to do this. There's a new modality of treatment which is there when doing endoscopic discectomy, if we do day in day out, or disc procedure. There are people who are smart enough, they are taking away the sinovertebral nerve, they are ablating this nerve, like we do a FACET nerve ablation. They're doing the sinovertebral nerve ablation because the pain is taken care of, because it will take really months for annulus to heal, and patient will keep complaining of the pain otherwise. Either you go inside, you burn the annular nerves from inside with the radiofrequency probes, or bioplasty or annuloplasty, or you burn out this nerve, or kind of sacrifice this sinovertebral nerve, and the pain is taken care of. This is very, very important. And see the arrangement, by the way. When you're doing intradiscal work, the ventral root comes first to you. Always remember. People have made injuries because they didn't realize there's no pain when you insert the ventral roots. It's only the motor thing is there, and they're checking for the sensory thing. So remember, sensory is only the dorsal one. Ventral has got no pain per se, or a very mild one, which is not really appreciated by the patient and the doctor, and they cause injuries and patient come with the limb lag. So this is to be understood. Very, very important point. Now this is a very, very good slide. This is what we're saying is there 90% of the fibers which is coming from the sinovertebral nerves, they are A delta and C fibers, they are carrying the pain, and 90% of them and most of them are from the anterior epidural space. Posterior epidural space doesn't have big fibers, and all these fibers are focused at the I told you about the PLL as well as the posterior annulus. That's where they are all kind of localized and focused. That's the reason why people complain so much of back pain, which radiologically many times you don't see many things, but that is what it is. This is what I was talking about, the rami complicantis RF. You don't have to go much further on, because then your sympathetic symphysis happens, and you don't have to be receded here. Your bare tip is here, and you're burning the nerve in there next to the body, and you don't come out because the segmental nerve is going to go from here, and that should not be burnt. That we have to be careful. Always do a stim. As and when you do a neurolysis, any procedure, always do a check, and be it stimulation for sensory, motor, and then proceed further. This is a very, very important lead, because sometime when you're going to do a work in here, you might meet with the genitofemoral nerve. You don't want that to happen, or you meet with the main nerve from L1, S2 or L3, and you don't want to burn them up. That's the reason. That's what I was trying to say. This is, you can call it a CRPS is lower back sometime. There's a back pain which has to be taken care of. You do a sympatholysis in there, and this is one of the way. You see the very good appearance of the retroperitoneal space. It is just like an epidural space, and you do a little of spread there. Best is the L2 because your nerve is entered through L2. The most of the fibers are carried through L2, or you can go to the specific branch and can do at the level also. Now about the radiological part of the disc procedures. When we are trying to enter into this L5S1, you try to go by side of the SAP, superiortical process. Remember, very, very important. Go by the side of SAP, that is in line with the disc space. Go by the side, we'll discuss it again a little later. And when you're doing all discography procedure or debulking or methylene blue or ozone, then you try to be in the center of the disc and put your chemical there or your drug or anything there. But when you want to do something to debulking, now close disc, you can debulk in the center of the disc. You want to take some nucleus out. But if you want to do a disc annular work or disc disruption work or PIVD work, you will have to come at the posterior 1/4 of the disc in the lateral view, and that is the whole work has to happen here. Nothing in the center or the anterior 2/3. No way, because you want to have that supporting structure there. So you don't want to handle the structure, because after all, body needs something to support itself. So you don't, otherwise what happens is you do a lot of work in there. There will be disc collapse syndrome, and there will be facial arthropathy, more of facial loading and more of facial pain, and that is no good. And by the way, when this collapses, the foramen also becomes narrow, and patients start having a secondary foramen narrowing or lateral canal narrowing, and the consequence problem coming up. So understand, this is the lateral view, this is the AP view. And when you're doing endo procedure, in the AP view, you may be coming right up to the other side of it, but in the lateral view, you're just staying there, as I mentioned earlier. We'll come to that again. This is what is discography. Sometime you have to do this procedure, because the one which is on MRI is not the disease or the painful disc sometime. So you might need to do a discography if you are in any doubt. Do it. Be sure. And this becomes all the more important when they want to do a bigger open surgery. And we can always do it during our endo procedure. We have to put in your first needle. You can always put in a dye and you do a discography on table for that matter and proceed further. Yes, some people have started doing a treatment on this part. I'll just explain you there. This is, by the way, empty disc syndrome. One of those beautiful slides of 2009, patient had a whole disc which is extruded outside or sequestrated for that matter. And I know how he became fine. He's absolutely fine. I saw him a few years later, is absolutely fine. You see there's no material inside the disc, and you're seeing this is a prone position, so dependent portion is with the dye and the other portion with the air. This is called empty disc syndrome. Just one of the interesting slides I thought I'll show you. Now this is important. When you do a discography, alone discography is not going to be enough until unless you do a CT, the post discogram CT. That gives you the best information about the disc integrity from the inner side. Otherwise MRI is very good for external disc integrity part, but internal disc integrity, internal disc disruptions, that all can be best in the CT discogram. And you have to manage these kind of problems because they are giving pain, back pain to the patient. Until unless this come out, you might have to manage this with one or the other debulking procedure. But here you just have to do annuloplasty or nucleoplasty for the matter, and your job is done. That is how it is best done. This is the grades, Dallas grades. 1, 2, they don't give much of a pain. As soon as getting to the peripheral fibers, they start getting pain. Do annuloplasty there, which goes further. There's a radial tears now going on, and you have to manage it. I want to educate you on one thing, that many times there will be multiple of these coming up, not just one of that. When we're doing endo disc procedure, we see one big disc fragment coming out, we just take that down and forget the small ones which is coming up, which are the disc disruptions in making. So you have to manage. It's like a hernia. You take the main hernia from ventral hernia in the body, abdomen you can call it, but then you have multiple small hernias which are in making. You treat all of them and do the needful. Lately what I'm doing is I'm doing a little of mesh annuloplasty. That's a new thing which I've started doing. So I close all those holes which are potentially can be a problem in the future. One of the slides from one of my friend, and this is the spinal pain pathology. Extraspinal, it can be ligaments, facets, muscle. We have to treat. They all are treatable for the matter. Very easy. You do a prolo and other treatment, physio and other things, and trigger point injections or Botox or maybe steroids or PRP or prolo. And facet, obviously we're going to talk about RF and prolo also. Disc is discogenic pain. Then a disc leak, chemical irritation of the nerves which is happening, and that is irritating. I told you earlier, disc hernia pressing on the nerve per se. That's a very big thing, and that needs an urgency. That's the urgency scenario. You have to manage it. Although I've seen disc absorption or resolution spontaneously also. So you have to calculate which patient needs procedure and which patient can be managed conservatively. And this is the intraspinal. The nerve mechanical compression on maybe because of the reason of disc per se, disc bulges, or fibrosis from the previous thing, or natural fibrosis, or facetal cyst and other thing which is there, or some lesion otherwise, or the nerve root chemical irritation coming from the disc. Look at this. This is not one of those things. It happens day in day out in our MRI thing. Look at the MRI. Disc collapse there, and there's a bulge of the disc. The annulus is bulged out. There's a hypertrophy of the ligament of flavum as well as the capsule. Facet, there's arthropathy is there, and look at the poor root. This is all compressed. Now, by the way, remember this is the root and this is the vessel per se next to the root, or maybe there may be vessel may be here. This is the dorsal and ventral roots. Ventral root and dorsal root, and this may be by the vessel around. This is very important to understand. There's a vessel, always a vessel there. We'll come to that again, because when doing a root block, it's very important to be conscious of this vessel. Now, about the modic changes, this can be painful for the patient per se, and we have to kind of manage the disc per se for the modic changes. Some people have started putting little of steroid if it's early disc disease, but I am a little fearful of putting steroid because of the infection reasons. Type 1 is when it's fluid-like look, type 2 is when it's fat-like look, and type 3 is when it's closest look, depending upon how chronic is the modic changes or how bad is the modic changes. This is very important. This has not been taught. This is one of the endoscopic work, when doing transmural endoscopy. Very important, very, very important slide, because many times there are so many pain reasons at the small area which cannot be addressed from the posteriorly. That is the whole point. This is a hidden zone of McNabb which is there, and maybe inflamed disc, maybe hypertrophied SAP, maybe capsule, tight capsule, maybe some ligaments, or maybe some fibrosis or inflammation of the root. And there's so much going on in here, and this area has to be well looked. Now we can go from the side. We call it a sagittal surgery from the side, and we are not doing a coronal work coming from the posteriorly. So this is interlaminar surgery is coronal surgery, and the endoscopic transmural surgery is a sagittal surgery, and this is giving a very, very good result. So if one has to be well versed with all these modalities of treatment. Now I don't think anybody would ever advocate a surgery for this disc, but yes, it is painful. Yes, it is degenerated. Yes, it is black disc. Yes, there is a small annular disruption and some HIZ. It needs some treatment. So there are different modalities of treatment. We'll come to that again. Now this era of least invasiveness, as far as we can be least invasively. One important thing we have to understand, when I go from here, when closer to the body, this is midline, closer to the midline, more anteriorly I go, more on the same side I go. When I go away from the body, when I distance myself away, this SAP being pivot, always remember, this you are acting against a pivot. Farther you go, posteriorly you come. So when you have a central disc work, you can come a little about 45 degree. When you have a posterior disc work, there is disruption, there is a bulge in here. You go a little further off on the skin, and we come in here posteriorly. And sometimes, by the way, there is a lot of big fragment in there. So you might have to come epidurally. So the people have started doing far lateral or epidural surgeries. That is outside in approach. That is many people are doing it, and they are very happy about it. They say, why should we go inside the disc when the whole problem is lying outside? But the other people will say, but the problem has come from inside. So whether you want to handle the terrace in your own territory, or you want to go inside the other zone and handle the terrace, that is what is to be seen. So this is what you have to understand, what is the best way. It is from case to case basis. That is very important. Spinal injections are the newer thing which is there. It is come before other works. Endoscopy, MIS and open surgery, it has proven itself over a period of time. Now this is what I was talking about. When there is a disc problem, what all we can do with the disc? We can do a thermal treatment like intradiscal RF bioplasty or RF annuloplasty. We'll detail all this. Mechanical decompression, we're going to do a laser work. I've got a laser machine on myself. One of the few people in the world who has got a laser machine by themselves, not by the hospital. It's my own laser machine. The coblation, very good tool. Decompressor, mechanical decompressor, hydrosesion or other nucleotomes are there. Disc-FX is good procedure to begin with. I want people to graduate over a period of time to higher procedure endoscopic discectomy, starting from the easy work, and keep, kind of expertising yourself, have confidence and go for higher work. Then Disc-FX, and next, this is about 3 mm tube, you do the work, and then you go on to endoscopic discectomy, which is the mainstay these days. Chemical decompression, yes, early disc disease, you should try. Chymopepin was very good, but it went off of the shelf because of the commercial reasons, and big companies have killed chymopepin. It's trying to come back again. Ozone is, yes, we did ozone for a few years to begin with. I still doing it sometime, It is a mummifying of the disc, but we have to be careful where is the right patient. We have to do it. And then we have a methylene blue which is coming in the China and people are doing it. This is about the radiology. This is what we are trying to see. Scotty dog, typical Scotty dog. I'm going to detail this. This is the eye of the Scotty dog, which is good for the vertebroplasty, which is the pedicle. We upper outer quadrant, we start here and we go inside into the bone without going through the medial border, without breaching the medial border of the pedicle. Very, very important. We'll discuss in the vertebroplasty. And when we are going at the RF, we are going to do RF at the junction of the SAP and the TP. This is the where we are going to do RF of the FACET RF denervation. When doing a FACET intraarticular injection, we're going to come right in here. You see very good, nice intraarticular injection. You don't always have to be right there in the center of the joint. No, you can just sit at the lower base of the joint, and you put your drug in there. Why you want to injure the cartilage of the joint? You can do it there. And lately speaking, not many people are advocating intraarticular injection. They say put periarticular. Don't put corticosteroid inside the joint. It is damaging to the joint. Periarticular injection, which is there, if it is inflammatory one. If it is degenerative, people are advocating go for the facet nerve block, or if it is diagnostically positive, go for a facet nerve RF, which is the right treatment actually. We will discuss detail RF a little later. And this is about the interlaminar window for epidural and the across the thing. People are doing interlaminar work. They are going from here to the other side, and you will see that thing coming up. I do balloon neuroplasties. I'll explain that. And for all interdiscal procedure, this is the place. This is the place you see next to the SAP. Go inside the disc. And how far you want to go inside the disc, how posterior you want to go inside the disc, will depend what angle you have made. More you kind of go away from this, and more the SAPs on the posterior. This is what we call it. This is the upper end plate of the vertebra. And if it is 30%, you're going to go about 30 degree. If you go to at middle of it, you're going to go about 45 degree. If you're going to go further on, it is go a little back in the SAP, then you're going to go posteriorly in the disc. That's what it is. We may be in about 10-20 degree from the skin. And that's what you intend for the endo procedure or annular procedure. You're not seeing the L5, S1 disc space in here. We'll see that later, but you're seeing already S1 root space. We'll come to that again. And that is what it is. When you want to go inside, you distance yourself. If you can't make a full angle, you distance yourself. Because when you're trying to make full angle, sometimes CM don't allow a good angle beyond 20 degree or 30 degree. You might have to distance. Or you do the line diagram, which you do for endoscopic discectomy. Or you go by the eyeballing. You understand how far I have to go and then go inside. Avoid iliac crest. There is iliac crest syndrome. Many people have gone for endo procedure and they have injured the nerves or the sheath there, or there are superior cranial nerves, and which causes problem. We'll discuss that a little later again. And that is what I was trying to say. For L5S1, this is Bermuda triangle. This is the you see the SAP iliac crest is coming on the way. So you have to go a cephalic tilt for the CM, and then you have to right angle where you can have a Bermuda triangle for interdiscal approach. For your nerve, you can do a block in here. But it's not advocated to do a block at subpedicular, which people used to do it. We are trying to do most of work in the Camden's triangle for obvious reasons, because the problem is in the Camden's, not there. So please understand, we'll come to that again. This is the ozone work we used to do, and we're still doing it. Some people are still doing it, and you should start with this to begin with, and then go for the further procedure. And this is what ozone looks like when you're inside the disc. It's all white disc, that must be empty and bad disc. And this is what is the ozone spreads. By the way, go inside, put 8 ml ozone inside, come out and put 4 ml ozone in the periradicular area. That is what has been taught, and it's about 30 Mac per ml of oxygen. And that is what ozone was you started, and people are still doing in Italy and all. They're still doing it. And then we go further, and now we are doing it. Now what we do is, we do ozone inside sometime, put in ozone here. Sometime what is, when it come out, I put my steroid injection. So I do interdiscal ozone, extradiscal I put my root block like lateral distal block for the steroids, and this gives a good response in combo. This is very good thing which is coming, and this is the thing of the future. Please understand, learn it now, know it now. This intradiscal biologics, people are really going in a right way, like a discography. Put your needle inside, and you have so many biological solutions coming in, like intradiscal, intraarticular, or transmural epidural steroids and other things. People are putting biologics there with good results. There are papers already there about this, biologic papers. And this is for BMAC. We going in the iliac crest, we are right there. It's easy procedure. I know why people worry so much about it, and it's just in there. But you should know whole thing. It becomes easy once you know it. For flying a plane by pilot is easy. For you, it's almost impossible. So that's more important. This is about the BMAC thing, and we go inside, take a solution out from adipose tissue and all, make stem cells, know it, start doing it. PRP definitely is on. That's a beginning step. This is next step. For many times you might need it. There was a very good paper, the interdiscal regeneration using PRP containing bone marrow derived mesenchymal stem cell MSCs. This investigation, and they found the combinations gives a better result than the PRP alone. And that was the paper was, and it was very good. One of our master has shown this slide, and this is what they are saying: the medication usage reduces, the functionality improves, and that's more important than what ultimately you're looking from biologics. They say regenerate the future, not only patient's future, your future also. Learn it, do it well. Now this is about the disruption, annular disruption. Annular fissure, they not always happen from the outside, they happen from inside also. So one has to understand, when it happens from inside, you capture it and seal it, and kind of you denerve it. That's what you're looking at, and that's what it is, and that is how it has been done with the disc effects. All my disc procedures, I don't leave the patient alone until unless I manage my annular work, denervation and annular sealing, because there is a heat sealing going on by the side of it. And that is what is bipolar RF is doing good job. Do with the bipolar RF, don't do with anything monopolar. And this is bioplasty. Put two needles here, right in front of the pedicle, and this has to be some distance, and it should be in the posterior kind of a 1/3, and that is what it is. And you're putting your heat thing through in there, and there is going to be a bioplasty going on in here. Look at this. This is the bioplasty happening, and this the temperature of the periphery of the disc is only 45 degree. Inside is about 55 degree. It's not hotter, by the way. It's a cool RF, and that is bioplasty all about. It is yet to prove itself. It is doing a good job. Some people who are fan of it, they are doing good job, especially for annular disruptions. Closed disc, not for open disc. Remember, you don't want heal to spill out. Now this patient comes with the 3 disc problems. Which one is painful? We have to do evocative discography, and which one needs treatment, accordingly we sort it out. We do a chemical one or thermal one we do a thermal one there, or we do a debulking one there. Each patient has got a multiple of them. Then we have a FACET and SI, other things. So you might have to do a multi-procedure for the same reason. And this is what we used to do in the beginning. Ozone, then graduate on this 2007, by the way, graduate on to decompressions. This is decom, initially very good tool. Know it, but don't wrap the nerve. Remember, it has to be inside the anything you do, you should be inside those two annuluses right there inside this. Don't go other side, because the abdomen is there. Don't come out, root is there. So one has to understand the philosophy. All these thermal or all these mechanical decompressions, and this is what it is. And now we debulk the material out, and it's good for debulking. Anything to do debulking is good, but I would be happier if I had to do a decompression along with the annuloplasty. And this is where the Camden's triangle is all about. You see the exiting nerves, you see the traversing nerve, and there's a triangle which is made. And by the way, triangle, this is not a Camden's triangle only, this Campbell's cone, by the way. The Camden's cone is there, because the triangle is not just the triangle one side, it's a 3-dimensional thing, it's a cone. So one has to understand the cone, and we put our sheath or anything instrument through the cone. Now this is what is called Camden's triangle for ages. Better we should know it as a Camden's cone. We go by side of the SAP into the disc, or for lateral recess block, or for other things. On the same slide, I want to educate on few things. This is where we want to normally people do facet joint injection. I'll be happier putting my facial joint injection here, putting drug in the lower recess without insulting the joint. If at all, I have to go intra-articular. Peri-articular you can do any time. You have to do RF. The RF nerve is coming here and branching here. You do a facet RF in there. I told you about interdiscal, and people have been doing 6 of subpedicular injection of the root. But the problem is the artery is coming by the side of it. I'll show you another picture. And that is, you have to be very careful. If you have to do it here, do retroneural. Always retroneural. Don't go front and touch the bone. Do retroneural. And that is the direction. Know the direction. And we do DRG work and all. I'll show you how we do DRG work. And this is my complicant is RF and sympathetic blocks are there. And this is about the slide which says if you have to do a little anterior work, you can just exiting root work, and you have to be coming closer to the root there or DRG. If you have to do a traversing root problem like paracentral disc which is issuing the traversing or canal stenosis, you have to come more posteriorly, and sometimes you have to do a facetectomy. By the way, for the same reason we do a partial facetectomy. It gives a very good result, and it's all doable. It's like this: you want to go more posterior, go further off. You see, understand this slide. You're coming closer on the skin, you go more posterior, go further off, because this is your pivot. SCP is your pivot, and that is what will decide how far you're going to go in. But remember, when you're going to go too far, You're not going to go, when you go to upper disc, you're not going to go and rupture the kidneys or viscera, retroperitoneum there. You have to be careful on that account. Now this is this is what I was talking. This is the renal thing or retroperitoneum. Understand. Practice all this in your scan rooms. Please, if you don't want any mishaps, practice this. And by the way, when I am talking about the upper ones, upper lumbar ones, there's a wide canal there. The neuroforamen is wide, the spinal dural canal is wide, the retroperitoneum comes. So we have to go more closer to the midline and we work in there. Once you're inside secured, then you can do anything you want, what you can want to do. This is the distance part I told you. Yeah, very important slide. More posterior you are in the, have a work in the disc. Farther you go from the skin, midline. Farther you go from the skin, midline, and less angle you make. But then you have to be adequately expert and trained. What technique which I have evolved, and I'll explain you that later. What I'll do is I try to come SAP and touch the posterior annulus there, right there, posterior annulus. As soon as I touch the annulus, I put my sheath dilator there and kind of, against the pivoting against the SAP, I kind of made a little more angle and then re-enter inside. You understand? I'm coming here. Now I'm pivoting this here and putting the sheath, not leaving the annulus, posterior annulus, walk on the posterior annulus and go more posteriorly or farther off and go inside. Very, very good technique. People are already doing epidural surgeries, I mentioned you openly. And this is what Koreans are very big, very good at it. They made angle scopes and they understand how we have to do it. They're going with angle scope, going inside epidurally posteropital space, not touching the disc at all and doing all the work there, be it adhesions, be it the disc problem. Important slide for one reason. If there is an upper disc migration, you start from below on the skin. If there is a straight disc, this is what is normal reference point. You may already made a reference point, but if the disc is low migrated or caudally migrated, you start from above because you want to see below. Same thing happens in the other side. Now this is what it is all about. This is the transfemoral epidural transfemoral endoscopy. This is interlaminar endoscopy, and this is contralateral transfemoral. What is happening is you're going all the way to the other side. And this contralateral and interlaminar, many people are very good. Doctor came and other people came and other people are very good at interlaminar cross. And yes, L5S1, when there's highly crest, there's a problem getting into the disc right angle, you can go transiliate. Easy, very good. Don't have to bother, don't have to make different angles, for many reasons. There are many reasons that you can't enter L5S1 because there's a small foramina is there's a large facet, the disc is literally placed and all those things are there. Or there's a large disc in there and you have to manage it. It is impossible to get to the disc fragment, so you can go the transiliate. This is the important, this is the subannular work. I told you, you have to be staying, everything has to be done just under the annulus because your disc might be bulged this much and you are still not at the disc, still inside the annulus. Subannular work, don't touch a posterior 2/3. Is very, very important, not leave it alone. And that is what where you're trying to put the fragment. Depending on where the fragment has gone out, you already know from your scans where the fragment has gone out. And this is the iliac crest, next to the iliac crest. At the end of the procedure and do a disc FX, you have to do a bipolar RF annuloplasty and annular denervation, which I told you earlier also. Now this patient has got a large disc. Patient has been done laminectomy, by the way. Understand, this is a post-surgical syndrome, shouldn't say failed back surgery, post-surgical syndrome, and there's a large fragment which is there. See, what surgeon normally sometimes do is they instead of touching this, because right in front of the cord, it is so fiery to kind of displace the cord coming from the posterior. You don't see anything, you just decompress and hope that this should be good. But remember, there's a lateral recess. Patient is complaining of lateral recess pain, there's a compression going on still, and that is not enough, good enough. Look at this slide. You can't leave this big fragment in the canal and leave it alone. So you have to kind of go and decompress. Or a patient which got a large disc which is there. You look at the very big disc fragment, young patient, 37 only, very big leg pain, already a motor symptom has started coming in. You don't leave them alone. You have to take the fragment out. This is the insulting fragment. Don't leave terrorists inside, take them out and kind of ablate it. Now this is what the red head I call it. And this is a red head which is the epidural space. There is a reaction, body is already trying to absorb and this body is already trying to react to this. Foreign fragment. This is not natural to the, by the way, remember, this is not natural to the disc space. This is not natural. And that is where there is a reaction going on. This is the mass which is there, which is causing the mass effect. And this is the neck of the hernia which is gone out of the disc. And this is the intradiscal portion. So you have to remove it. And yes, this, you have a radiological resolution, but it's not always there. But try to get a scan done and see how you're doing your good work on. Initially we used to avoid, but lately I'm doing MRI, post-surgical MRIs to really know, because patient may rethrow fragment later on and we don't want to be blamed for that. Now this is what I was trying to say. This is the traversing route. This is a dura you're seeing some fibers of PLL, and you see the interdiscal space. Some people have started doing the fibrin plug, Darwin plug. Dr. Gore and team is doing good job. They put inside, they don't want to leave the hole there, open there, and this is causing a natural regenerative medicine. Very, very good technique, and I think it should be adopted. Very easy. Take 10 ml of blood, put in a sterile tube, centrifuge about 10 minutes at 3000 rpm, leave it for another 10 minutes, no anticoagulant in there. There will be a fibrin plug which will be formed. Put the fibrin plug through the same sheath which you have and push it back into the defect there, and it kind of seals the defect and it heals the defect also, for that matter. And that is the beauty of this thing. As I told you, I've already started doing the mesh, like we do a mesh hernioplasty. I'm doing a disc hernioplasty, or that way, mesh disc hernioplasty myself also. And that is another some slide. This is where your interdiscal portion remove the thing. This is where you have cut the annulus, you want it to heal back, fibrin plug or mesh, and then you have all this free route, which is free floating route. We put a plug on the sheath and you see the free floating route. Neurostructure should be free, easy, and you give the space back to the neurostructure, because that is the native place for the nerve, not for the disc. Now, yes, many people post-surgically, they have this problem. They are burning the back because you have done a screw fixation, but there are some issues still left. It may be the facet orthopathy, maybe something else. One has to look for this. Or patient has got a bad facet in there. Look at this bad facet. Not a very big disc, so sometimes patient doesn't want to go for surgery, or surgeon doesn't want to do a surgery on such patient, because the results are not very great with the bad facets around there. So really one has to look for the treatment modality there. Or for that angle, there is a mechanical stress in part of the scoliosis, and you obviously there's going to be a loading on these facet joints, so simple reasons, and this gives a facet trap. Look at this. This is the root, poor root in there. The vessels I told you, again I'm just showing you the vessels, please understand, important slide. And this is the disc which is kind of bulge, and you have a nuclear material coming in here, annulus getting bulge, and annulus is disrupted there, and you have a facet knot, we call it SAP knot. There is a SAP which has gone a little up, if this collapses further on, and there is a capsule hypertrophy or ligament flavum hypertrophy which is causing the problem. So in totality, this faceter area is narrowed and is compromised, and that's where nerve is very, very sensitive. DRG is very, very sensitive, and there's a lot of insult going on for the root. That poor root, you can't do much about it except cry. Right? This is, there are many times you have a facet syndrome or radicular pain or root pain or SI joint pain, and they look alike, clinically, sometimes it's so confusing, or they may be incidentally present together, So one has to really understand, if you just do this and don't do this and it's already there, so patient will still complain of this. So both ways, and understand, we have to do a combo work. And this slide I sometimes put for the same reason. There's a lumbar sympathectomy going on, there is a rami complicatus RF going on, and there is a subpadicular root block which is not advocated these days. We try to do a root block in the Camus triangle, and this is what we are doing, a RF radio frequency. This is the TP, and we are doing the SAP junction. We're doing and this is the intra-articular injection, or that way periarticular injection, and this is a typical interlaminar epidural which is going on. So one of those slides which I teach my students sometime and understand, and I give them practice to do also on dummy. This, by the way, dummy or mannequin. Now look at this. If you look at any patient with a wet facet, open facet, bad, because they have instability, they have a problem, they have a pain, and addressing the disc alone might increase the problem further on. And this is what we're going to do. Intradiscal avoided, intra-articular. We do a periarticular. Lately you see a bad facet now in there, and we're doing a facet RF which is there. You understand the nerve, and you do a nerve block for testing, and then do RF. We'll come to that again and understand. This is the intra-articular. I told you, try to do the lower recess. This is the one of the previous slides. Lower recess, this is a large recess. You can put your drug in there, it will going to walk in. It's like a knee or shoulder. Any place you go, it will walk by itself and do intra-articular or periarticular. But lately people have seen that the PRP works better than steroid over a period of time, or long period of time. The steroid initially is good, but then it starts weaning off at about 2 months time, and then steroid goes down and patient comes back with the pain. But if you've done a PRP, patient will get a regeneration, and that is proven to be better. So you can do a PRP, and you can do intra-articular PRP. There's no problem. Intra-articular steroid is a problem, PRP, just like knee. Knee you give steroid or PRP, PRP will be better in long term scale because this regenerative medicine. Same goes here because cartilage is there obviously. And that is what is called you fertilize and let the natural thing happen. Another good slide from our friend Agnes, and this is what we say when there is lower back pain, lot of lumbago going on. And you have so many ligaments, so many things coming up. You have iliolumbar ligament, SST, ST ligament, sacrospinous secondostal ligament, supraspinous ligament going on. The facet, the SI joint, posterior capsule, and the transfer thoracofascia, thoracolumbar fascia, which is there. And or I call it iliac crest syndrome for reason of fascia or because of the cluneal nerves walking up, because the nerves are branching and walking up there. They all can be painful for one or the other reason, or they all can be together. But prolo or you can always do, PRP prolo you can always do, and it is proven to be very, very good results. Same with the cervical area, when there is a whiplash injury, very nasty, very, very nasty thing. And you have the ligament injury, you have the joint capsule injury going on, you have the disc which is there is some amount of listhesis going on, and the poor road can be getting compromised. This all can be best handled in one go by the PRP, and they have shown this PRP is given a better result than the steroid any day. And this is a natural curve, and this is in the extension and the flexion. There is a translation going on. Can you see this? When the translation is more than 3.5 is disease, 2.7 we should address this, and that is what they are seeing. And they say plain cervical X-ray doesn't tell you much, but if you do a flexion extension view like we do in the lumbar one also for instability, that gives a 99% surety of the problem. And this is what they talk about, all this regenerative aspect. And you are putting your drug. We're going to talk about FACET RF, but this is putting drug on and around the FACET capsule. That's what has been shown in here, like this. And this is a combination. You see, people are doing superimposition these days. Technology is improving in a very big way. So what do you tell your patient, PRP patient? Any place you do PRP, any part of the body you do PRP, tennis elbow, shoulder, plantar fasciitis, any place, tell them it is over a period of time there is going to be an increase in the pain for some time, pro-inflammatory pain, and there will be a little on stabilization going on, and the tissue healing is going on, and with time it is a cure, by the way, not just managing the pain, it's curing the pain. So if you want to have a long-term patient with the long-term relief, go for regenerative medicine. Now this is a very good paper I just saw a day back, ultrasound guided cervical intradiscal injection with the PRP with fluoroscopic validation for the treatment of cervical discogenic pain. Beautiful thing, beautiful work. And you go inside, although we're doing fluoro, yes for sure, but they are, see with the fluoro the one problem is you don't see the structures on the way, like vascular structures or viscera on the way, but the ultrasound you're seeing everything. If you can put it on ultrasound guidance and then vouch on the X-ray, you're safe, you're secured with the from the injury to the viscera and vessels, and you're very sure that you are inside the disc and putting your dye in there along with the regenerative medicine. Very good paper. Same with the SI joint. People are doing SI or periarticle. I told you SI has got a lot of ligament. By the way, sacroiliac joint is all to do with the ligaments, put by ligaments. You see, there is nothing which can carry the weight from there to there. It's all ligament held. Like ankle is all ligament held. So there's, when the ankle pain is there, is a lot of ligament to work in. So fluorotherapy is very, very helpful. People are doing a fusion. This is what is happening. Coming already, people are doing navigation techniques. They're doing fusion. So much going on. Technology is advancing. Learn it. Ultrasound, CT fusion, and there are so many, and the navigation is going on. So this is a magnetic thing, and we should learn all this. So always when I do my session, I always take a class on the scan room for 2-3 hours. I take them to my MRI CT scan room and show all images in the 3D format, and try to educate, because it's an eye opener for me and for them also. So this is such a beautiful thing. Know the technology, know the images, know by yourself. Oh yes, you should have a radiological friend, but know by yourself. And this is what Scotty dog is all about. Look at this Scotty dog. This is the transfer process. This is the oblique view. By the way, posterior oblique view. This is the ear, which is the Scotty dog SAP, and you have to do your FACET RF with the eye for vertiplasty. You should know this is the pedicle now for your pedicle screw fixations. This is the pars for pars defect. You have to look for this, and then obviously this is the SAP, the inferior articular process IAP, and then interlaminar window is coming from there. And now what we are looking at now is, when you're going from in here, you're going for intradiscal approach or lateral recess procedure. People have been doing a root block here, but that's not advised. It is advised to do it. I would never ever do a root block there until unless I'm doing endoscopic disc procedure. Suppose I made a big rent in the annulus. I won't go in here, put in my steroid there. I like to put it there or come a level below, because when I put my steroid here, it is going to walk up. It won't walk into the disc. So that is something important. I do it, but not same day, after 1 week mostly. because I don't want my disc to have steroid, especially after my procedure. Any discitis can be blamed to me only, and obviously yes. And this is what it is, the target for L5S1. When trying to look at L4-5, you're going by side of SAP for lateral interdiscal procedure. This is your root. Understand, your root is always hugging the pedicle. Remember this philosophy. Always hugging the pedicle. It's trying to go out, the pedicle is stopping it, in other words. And it's just trying to go in there, and this is the angle of the root. And this is the Camus triangle. We talk Camus triangle a lot. This is the Camus triangle is all about, Camus cone for that matter. And here is one direction, one view, so it's a Camus triangle in 2D view. And this is where we are trying to do our interdiscal work. And for L5S1, you don't see it's there, but you do a cephalic tilt and you see a very big opening up at the L5S1. On the cephalic tilt, this is iliac crest. This is normally a problem when you're doing interdiscal approach. Some people are doing transiliac also. And this is the S1 foramina. I put a needle here. From S1 take, there's a twig coming and doing a pain in the L5S1 joint. For L5S1, you take 3 nerves. A twig, upcoming twig from the S1, the L5 per se here, and L4 which is going to come and give a branch in there. For each facet, you burn 2 nerves, level and above, level and above, level and above. But for few facets, you do 2 nerves, C71, and you do as L5S1, you do 3 nerves, 1 level from below also. This is an important slide. And this is where we are going to go into the disc. And more posterior you want to go, typically speaking, more posterior you want to go in the disc, farther you start off, simple. And this is important, facet anatomy. You're seeing everything in there, and very important. This is the one facet nerve which is supplying at level and level below. The facet nerve is supplying level and below, but facet joint is supplied by level and level above. This is important to understand. So when I have a L5S1 facet, L4-5 facet, I'll do L4 and the one above, right? So that is how it is going to be the facetal nerve. Understand, the facetal nerve always has to go through the memorized ligament mostly. Now there are some people who says no, it might bypass this, but in surgical scenario they may be different, or in a very bad facial arthropathy may be a little different. So that's why you have to do devise ways that you don't miss on this nerve. Many people miss this nerves, and why many times facial denervation fails. We'll come to that again after a minute. This is where the facial nerve is there, medial branch. There are lateral branch, intermediate branch, lateral branches. Leave them alone. They are supplying the spiny muscles, erector spiny, other muscles. You don't want to, or multifidus. You don't want to weaken the nerve. Try to go to the medial. That's why I say medial branch. That's why I always say medial branch. Come parallel to that. Avoid going to the main trunk, because that will burn these one also. Medial branch is a membranous ligament, and that's getting into the joint. Try to burn that and stay parallel as possible. This is nerve coming as parallel. If you're going away for cool RF, yes, you can go from any angle. We'll explain that. But if you're going for this, come parallel, come from below, and that is what direction is nerve is all about. Coming from below, going up. You may do 1 or 2 lesions way back, no problem. But don't go further on and burn the main branches there. This is to be understood. And that is there, the lateral view of it. You see, you're coming from below up and just sitting right in there, and foramina is open. This is, by the way, animation kind of my pictogram to understand where the nerve lies and where you have to burn the nerve in. This is the picture. Never ever get into the foramen, because people have done this, but always, you never do a RF without doing a stim, sensory motor stim. I've had a very senior pain specialist from USA, one of my relative, young boy, 21 year, went for RF, and his leg is limp now. So this is where it might have spilled. Sometime what happens? Either you oversedate the patient, or you give a lot of LA. Now what is happening is, if you are given 0.2, 0.3 ml of LA, understand, very important point in here. You are on the facial nerve. You put 0.5 and more. Your LA spills onto the main root. Now what is happening is, you've done a 0.5, 1 ml LA. Your root is also numb now. You're doing RF. You don't know you're doing RF, or maybe malpositioning or needle position change, or anything happened during the procedure part, and you're doing an RF here, and now there is a good heat which is conducting along with the LA. There's LA volume also onto the main root, and patient can get limp. There have been accidents. Please understand, we have all seniors have gone through all those accidents. We are trying to educate our friends and people who are joining newbies not to let this happen. This is very, very demoralizing otherwise, because patient is on your head. Yes, it recovers. If you're not really very bad, or you're not overzealous with the nerve, it recovers mostly. So that's why what happens when you do facial denervation, patient comes a few months to few years back again to you, because nature does a repair of the nerve again back. So that is to be understood. Now this is what when we're trying to do a little of kind of enlargement of the lesion, Now we either use a bend nerve. I use it very often in quite many of my procedures because I want navigability inside. It walks towards the sharper edge. Remember, all your needles which are sharper, when you trying to push through, any needle you start from here, it will walk like this. Anything which is there, even if you are trying to go straight, because it is cutting on the sharper edge, so it is go toward the sharper edge. Now same thing which we make use of is we rotate around and we kind of take it to the other side. So you can cover more area with the bend needle. Now there are some needles which are already there, preformed. Another thing is we use a bipole. You are seeing a bipole, people are doing bipole work, a very good job putting on the ganglion and do a bipole and burn this. This is one thing, 1 centimeter apart, or they already have got a tripole like this. It gives a bigger lesion like this, tripole lesion. And they have their multi-tined needles are there where this needle, the tip comes out and you can burn like that. Like this is the tip coming out, you burning the nerve. So these are new things which is coming, very good. And then obviously yes, we have a cool RF already with us, and this is where the cool RF, it has got a globular lesion, number 1. Number 2, lesion is as much ahead, as much back edge as ahead of the needle. Don't you forget this, because there have been injuries because of this going ahead of the lesion. There, if the bone is there, bone can get injury. If there is a root which is the main nerve which is going beyond the facet, which is the basically branch of the main nerve, you can do the ventral nerve, you can really burn that part of it, or dorsal nerve for the matter. You have to take only the branch. But in the conventional RF which we have, a routine ones, is a kind of a longitudinal lesion, there is a less spill in front of it. Except when you are doing a pulse RF is always at the tip of the needle. So you come perpendicular, doing pulse RF, come perpendicular, like this nerve and this is the needle. When you are doing a conventional RF, you come parallel to the nerve as far as possible. You may be a little less angled, but as far as possible. So it's very important. But yes, if you are coming with the cool one, you have to go a little further off, because you're going to anyway burn the nerve off, but there may be structure which is beyond the nerve which can get burned. So you have to be careful on this. So people have done burn, especially in thin patients. There have been skin burns in thin patients. When doing SI joint work, when doing intercostal, people doing intercostal cool RF, without realizing that this can cause all this kind of problems. So you have to be careful on this. There the cryo is very good. In few places you can use cryo. It does equal effective work, although a shorter duration, but less of dysesthesia and less of problem to the patient. But yes, for shorter duration, cryo is a very good modality that can be well used of. This is what I am saying. Sometimes a combo. If I have only 3 needles, I have to do 4 or 5 level. I do conventional one also. I've got both the machines on me and the cool needles in here. You see these needles are a little thicker. And this is when doing conventional one. Understand, you can go up till here and do your burn, because burn is going to be here. When you cool RF, retreat it. And because your lesion is going to be in front of this also. So otherwise it will go further. Suppose this was cool RF, and do a burn here, the lesion will go like this. So you don't want to take chances. Now this is the lysis with the PIVD. We keep seeing this. This is a very common entity in our clinical practice. If you have this lesion, it attracts you, but that this distracts me. So I don't want to go ahead with this. If there is another problem going, if there is a stable lysis with the flexion extension, you can do your endoscopic work. If it is unstable, if there is a play, don't. If there is a play, let it go for implantation and fixation and other things. That is the righteous treatment for those patients. Like if there is a lysis only, but stable lysis, yes, I can do any work in there because it's stable. But if it's unstable, I told you the problem. The CT picks it up. Sometimes you don't pick it in the routine MRI. Get a CT or get a bone scan. Young people, sports people, many people have these injuries coming up. All tests otherwise are negative. You get a scan done and you pick up the hot lesion there, and you know that's the problem. Always quantify grade your lysis. Grade 1 up to 25%, grade 2, grade 3 and grade 4. Anything grade 1 and above, you should be suspicious whether you should touch or not. Go for a flexion extension. Even in grade 1 for that matter. And there is a play, maximum play is, it's going to grade 2 and beyond. Please advise to all my friends, don't touch, leave them to the fixation part. This is very important because it's so tempting sometimes to go ahead. We have burned our fingers, so please don't do that. FACET RF, post-surgically, you fix it. Somebody fix it. And still there is a problem. Look, there is a transient syndrome. This joint is fixed, there is a hypermobility. Now this joint is in trouble. Now they have to do a FACET RF for the same reason at this level. So these people keep coming to you for one or the other reason, even post-surgically. Or for that matter, FACET is very much known in a younger age population also, and you have to do your FACET work in there. This young boy who came with the back pain, I thought maybe it's infection, tuberculosis being common, or facetal pain. We saw what is the osteoidostoma. Put your needle inside, do your RF, 100% cure, and that is what it is there. One other patient I had a cervical C2, I'll show you that later on. This is the important thing, synovial cyst. People come with this, with the dramatic kind of a symptom coming in, and equally dramatic is the resolution. They have a certain, because facet cyst is like a ganglion of the of the wrist. It's like a ganglion of the facetal joint, and it suddenly pops in, and suddenly there is acute excruciating pain, leg pain, because it comes and presses on the nerve, one of the nerves. And once you go inside, take a needle in there, you debulk it, put in a little steroid around it. That should be the good job. Sometimes I try to do either like epidurally or endoscopically, like either coming from the side, or people doing interlaminar. I do epiduroscopy. I have got epiduroscope. Go inside, put my laser there, just cut open through this, and that should be good. You de-roof the cyst, and that is it. And it's a very, very good result. Believe me, don't leave this patient alone, because they're in very, very big pain. You can do it as a palliative procedure for the timing before surgery is contemplated, but that's what normally is. You don't have to go for surgery thereafter. This is how I do it. Interlaminar epidural, go laterally right in front of the joint, and that's where the cyst lies. I have an MRI picture on me, and do my burst of the cyst or aspirate the cyst like a ganglion, and put in your drug around the root. Now you don't have to be putting inside, you can put it around. You can put inside, it will go to the joint, no problem. And that's what it is. This is lateral interlaminar epidural, very good lately evolved for the root block also. Instead of going from the side, many times there have been issues, so you can go from the medial side and do your root block there. These are few slides further on for the same reason. This is the FACET ultrasound guided. People are getting more and more onto the ultrasound. Remember, anything in the periphery, ultrasound is the first modality or first choice of imaging for procedure. Anything to do with the spine, mostly the first choice procedure used to be the CM or fluoro guidance, but it is changing lately with the good advent and experience with the ultrasound images, especially cervical. The ultrasound is very good, but in lumbar also people are trying to expertise. But yes, you should always have a backup of both till you expertise in the ultrasound, and that is how you're trying to do. This is where you're trying to sit on the groove there where the nerve is there. When trying to put the nerve, you're doing a kind of a transverse thing, but then you put it longitudinal also. When doing RF, for a block it's okay, you can do it here, but for RF you have to really understand you are the proximal part of the thing, because we put a longitudinal section, you see those trident, and you should do the proximal part of the, or cephalic part of the trident. That's very, very important. This is where you're taking a needle in there at the TP junction, SAP TP junction. You see this aeroplane view, beautiful aeroplane view, and this is where you're doing intraarticular injection. The top of this pillar you have the intraarticular injection, and that's where, don't go too far because you have spinal canal there, and this is a TP. It shows you have a good machine, experience, expertise. It shows, and you can do this. You intraarticular work, PRP, you can always do this. You're not worried even if he goes intraspinal for some reason. You're not worried. But here, yes, for steroid you have to be extra cautious, especially with LA particular steroid. Yes. Now you're doing intraarticular injection in there. There's a very good thing which is coming lately is the peripheral nerve stimulation for the facetal pain or back pain. They found very good study. It surprised me too. That you put a lead next to the multifidus muscle, and this is the spine in there, and you do a stim and peripheral stim, and the pain goes. Sometimes even if your lead is gone, the pain relief is still continues for months together thereafter. This is a very good thing, which is the latest find, by the way, peripheral nerve stimulation. This picture is important for many reasons. This is rabbit view we call it, or the bunny view, and this is where you have the vertebral body. This is the TP process, and then you have three muscles, the quadratus lumborum, psoas, and the rectus spinae muscle. We know trifoil appearance we call it, and for the psoas block we can go in there, come from the back. Right there, this is important. You should know these anatomy, these few things, very important. You can go do your lumbar sympathectomy here. You can come and do your supraapicus plexus block or lumbar sympathectomy, I told you earlier. And this is how it is. So these are few things which is doable. And this is from Helen. And this is what we're trying to do. We're doing intercostal block, and then we're going to perivertebral block. Very, very good block. Very, very good block. Ultrasound is a very good modality for that matter. And I tell you, believe me, many times torso pain can best be handled with the perivertebral block, or I sometimes if it's cancer I do even epidural or intrathecal block. I'll show you that. But for chronic pain you can just do this perivertebral block. It gives a good result, and that is what is when you're doing intercostal, you're doing your work in there into the intercostal area. When you're doing your perivertebral block, there is a costal ligament, there's a triangular space which is there, and you do this. This is rib, by the way. This is the TP and rib, and you have a TP, and you come from here and you just put your drug in there. It gives a good block. Don't miss on these patients. Very, very good results. Now this is about the Bartheloti syndrome. I have about 5% patients who have a Bartheloti either before or after procedure. So if you miss this, they have a problem. Even if I don't do anything, people have Bartheloti syndrome, they can be in pain. You can manage, address, very easy. Look at this, put your needle there. Look at this transition vertebra here. Can you see this? And there's a pain coming up. Remember, this slide is especially put for the simple reason. There is a root which is the L4 root which is coming. It is coming right in front of this Bartheloti area. If I put my neurotic agent, which I do sometimes put it, like phenol and all, if it spills in front, it will burn this nerve. So what I lately do is I put in the needle there, do a stim at the maximum stim for the sensory and motor. If my roots are not getting talking, that means there is no leg symptom, I go and put in a little of phenol in there. Otherwise, just RF will be at one spot, but the joint, this pseudoarthrosis is long. This pseudoarthrosis is long pseudoarthrosis. Putting RF in one place is not going to help this joint. So I want to put in a little more of neurotic agent, or you can put in a depot to begin with. LA depot on the testing side, and then in the second sitting you might do a thing. But remember, you didn't puncture the interior to this because your root is coming. Like look at this. I'm just trying to show another such patient. So this is a very, very common problem which is there. So I do address these patients. Another common problem which I see with many patients is there is a kind of a rib tip syndrome. Sharp ribs. Like sharp tooth is haunting the tongue. There's a sharp shoe which is bothering the foot. Same way rib tip. Now you can call it a QL syndrome, quadratus lumbar syndrome. This is a choice. Or sometimes the Leclerc syndrome. But I have seen good number of patients, they cry out of pain when they lie in the bed, and they come crying. You put your drug in there, LA plus steroid when first go, they are very, very happy, and it's a diagnostic also. Second go, you can do a phenol here, or you can do intercostal block here. So doing intercostal block, one or the other is a phenol or RF, will do the needful. So they get a very good relief. And like a levator scapulae syndrome, people have this problem. So you should know about these things, and they can be very well managed. Knowing is more important. This is what I used to do for fluoroguidance. Floating rib tip, using the final rib tip here. Rib tip, take your needle to the rib tip, walk off the rib, you call it, walk off the rib and do your LA block in there. LA with steroid, or sometimes I do a low concentration phenol, 3, 4, 5% phenol, which is kind of prolotherapy also, frankly. And now this patient has got a pain below the L5S1 area. Now this, if there's a facial pain, you have more of the pain here. This pain is either L5S1 facet or SI joint pain. People will come, even post-surgically, even otherwise. And this is the SI joint pain, the pain map. And you do a radiology. Yes, if you see this, this is clearly evident. If it is spondyloarthropathy, treat medically for sure. If it is tuberculosis, treat medically for sure. But yes, pain can well be managed with your own interventions. For inflammatory, steroid. Don't put steroid for the infective ones. And that's where you do a two joint view. You see two joints, and you just rotate it. You make it a single space at the bottom of it. And instead of two joint lines, you see one joint line there. Put your needle in there and put your drug. By the way, that's the synovial area, and this all is the fibrous area otherwise. So you always try to address from here and put your drug in there. Yes, diagnostic. Steroid plus LA, diagnostic. Don't over inflate, because the rupturing joint can be more painful sometime. Know the volume of the joint. Be it facet, be it finger, be it any joint, be it shoulder, be it knee. Know the volume, how much it accommodates. Don't pressurize, over pressurize, don't burst the joint. It can be very nasty pain otherwise. Understand? Yes, some people say when you burst the joint because it's degenerated, there's a spill around the joint, periarticular. Obviously, it is going to give a relief. Some people say don't go intra-articular. Yes, they say even doing periarticular work is equally effective. Agreed? That is one of the modality of treatment, depending on patient to patient and choice, your personal choice. Yes, if it still comes back. Yes, another thing is PRP is taken over. In degenerative joint, PRP is better option, right? And then you have the joint which is ultrasound guidance is coming a big way. Now here is the big iliac crest, and here this is the joint. You don't want to go in there. You come a little lower down in front of the S2 foramina. When you go walk out the S2 foramina, see what we do is we start from go up and look, or you start seeing the S1, S2. So I go side of the S2 foramina and you see the joint line in there. This is the iliac crest now. You can walk in easily and you can do your work there, intra-articular work. For sure, you should do a RF. If it is chronic, if it's long term, or you want a long term relief, if patient keeps coming back. Now this is where we do an RF. We used to do it conventionally one, and we walk on the bipolar, like a pellucid lesion. If you don't want to put 6 needle, you use 2 needle and keep walking. Remove this from here, take this here. Now remove this from here, take this, walking pellucid lesion. And you can walk like leapfrog method. You can burn all this by the side of the foraminas, or you do the RF, the cool RF. Because there's a lot of variation in the nerve into the joint coming out of the foraminas, the depth wise and the direction wise. There is totally kind of a astray, where it goes anywhere. So you taking these big lesions, 3 lesions here, 3 lesions here, 2 lesions here, and another 1 lesion at L5, another one at L4 will do the needful. It takes a lot of time with the cool RF, but yes, you are more sure of the effect. There is simplicity, which used to come from here and take it up like this, goes up till here, and you do a monopolar bipolar lesion, but you should be expert how to do it. Another important lead is, many times you don't see the foraminas, but you always see the Chinese cap sign. Remember, this is a Chinese cap sign, and the foramina is just under the Chinese cap. There is a Chinese cap, there is a foramina here. Chinese cap, there is a foramina. Chinese cap, there is a foramina. This is very important. If you don't see the foramina, look for the Chinese cap, like right in here. Now another thing which is coming lately is, another very important and useful thing is peripheral nerve stimulation. You can just take in there, do your stimulator inside, and it's just stick onto the body, and it gives take care of the pain. So this is another thing, and you can do permanent if need be. If this succeeds, you can go for permanent. This is the piriformis syndrome, and what we do is we just doing the piriformis work. I think I'll take a break after a few minutes, and then people have a little of 2-3 minutes break, and then we'll restart. This is the piriformis in here, and there's a sciatic nerve pain which is coming. Piriform itself can be painful, known entity, you can test for it, and you do your intrapiriformis steroid this or Botox, and then you come in here, or PRP for the matter lately, and do your sciatic nerve block. If you're good in your ultrasound, you can really see the sciatic nerve, longitudinal section, and you can really see the sciatic nerve going if there's an entrapment going on in there. This is we used to do the fluoro guidance, do a block, piriformis block, and along with that pudendal sometime. Pudendal can be reason because it is giving a gluteal pain. We're talking about lower back pain. We don't know whether it's the caudal area which is causing pain or the pudendal. Know the pudendal nerve problem and treat it. This is spiroclonial nerve entrapment syndrome, and people don't talk about this. This is very, very important slide. Now we have all these nerves coming from here. These are the dorsal branches and coming from these ones, and the superior, medial, inferior clonial nerves also. And you should know about this. There sometimes is the reason for the pain. You go walk on the iliac crest and do your drug deposition there. It works great. And some people have done an open surgery, entrapment syndrome, release entrapment, like the radial nerve entrapment, carpal tunnel syndrome. Yes, this is the coccydynia, the tailbone pain. You take a needle in there and you do periarticular. First of all, do a spread of depot steroid and other things in here. But a impar block again works very good. Go inside, do a RF of the impar, do a little of phenolization or alcohol in there, and that works much longer, better than putting. So what I do is take my needle there, do impar work, come out and do my steroid work here. And if there is a coccygeal nerve issue, I take my needle in there, same needle, and do my coccygeal nerve RF in there. I'll show you in the next slide. But one important thing I want to mention, when you're going inside for the pudendal thing, the coccygeal thing, impar block, there's a large gas shadow. So please be careful. It has to be empty rectum as far as possible. Patient will come with this big shadow in there because you're risking your needle might get into the rectum, and you have had it because you have to come out through this sacrococcygeal disc. It will get discitis and nonsense. All this big nonsense comes in, and then it's a very, very big problem. I had a patient who is the wife of a senior most neurosurgeon of the London, and she had had this kind of discitis. They had to go and do the disc removal. Remember. So please understand, these are known things. We don't talk out of just in the air. These are facts. And this is the coccygeal RF, I told you. We just get it next to the coccygeal nerve in there, in the coccygeal groove. Both sides, do RF, very good lasting relief. Yes, I told you when you doing all this work in there, there can be reason in the lateral hip syndrome, which may be there right from the beginning, or when patient lies in the bed, especially in corona times, people or patient who have been bedridden for a long time, and they're sleeping on the sides, they have all this plantar fasciitis coming in. Put a needle in there, ultrasound guidance, do your drug deposition, works good, steroid or PRP, you have a choice in there. So I'll take a break for 2 minutes. The company people can be there, and I'll take up from here because now we have a leg pain and neuroplasty coming in. I think I wouldn't be able to finish whole my talk, so we'll somewhere stop when you people are saturated. I'll take. This is my video is on, by the way. Let me see my video. My video is on.
Yes. Video is on and the slide is on.
Fine. So we are going ahead. This is what is the Camden triangle is all about. We talked a lot about this stuff, and we should know this is our mainstay when you're doing a spinal work. This is a mainstay, and this is what the DRG is. When this the root comes in here, this is what the DRG in there, and this is where we do the safe triangle approach with the subpedicular injection there. We're looking from inside, from the cut section, but there's a large area which is there and which is next to the disc where you can really Camden's triangle or Camden's cone where you can do your needful. And by the way, this is the more important because your disc is bothering the traversing route there or exiting route there. So once you put your drug in there, you're going to populate both the routes. But if you put in drug in there, you're going to populate this and the route above. So that's the problem which happens many number of times. I'll explain you once more. You have to put more volumes, number one, and this doesn't address the problem which is the disco-radicular conflict is going on here. So this doesn't address the disco-radicular conflict. So you put a small volume, concentrated drug on this side only, that's okay. But if you do internal epidural, the drug might go more on the other side, which is not the pathological one. So one has to be careful where you have to address. This is very, very important from quarter point of view. This is the femoral anatomy. This is the one which is a normal route. This is the vessels around in there, and this is where the artery is exactly. Understand the artery part. Artery is here. This all is a veins, by the way. The artery is here. So you're not coming in here and insulting the artery. We'll come to that again. This is where there's impingement going on. You look at the two normal and compromised one. Some disc bulge, some facial hypertrophy, some narrowing of the foramen, and this is where the poor root is getting compressed. And this is a very important slide. You're actually seeing the root coming out, making a DRG, and then making a root again with the ventral root also joins in, and this is the DRG part of it. Now why I showed you this slide? Because when you do a root block here, either you do a subpedicular there, or you do a Camden's triangle approach there. This is a Camden's triangle. Can you see a nice beautiful Camden's triangle here? Approach here, but this is shown when sometimes you have to do a DRG work, whether you do a DRG medication or want to do a DRG pulse RF, you have to go dorsal to the DRG, and that is where this picture is for that point of view. Same thing showing in the MRI slides. Subpedicular, the Camden's subpedicular. The Camden's is the one which is addressing this and the next one, right there. That's what more important. This slide is important from point of view that your spinal arteries are coming here, right? There is a direct branch of the aorta, understand? So they bleed massively, especially artery of Adenoids, which is their large artery. If you touch it, it can be very, very big problem from bleed point of view and the supply. After all, it's a cord supply, and the cord arteries are end arteries, remember. So you have to be careful when you are going in here. That's where we see when doing some work at the base of the vertebra, like a rami communicantis, and your spinal arteries are next to that, this can be a little of messy scenario. So you don't touch the bone, stay away from the bone, aspirate and see your blood is not showing up. You have to be careful. Don't use very thick needles, use thinner needles here, because you don't want a thick needle injuring the spinal arteries. And that is where rami, you're coming from the underneath and doing a rami communicantis, if at all you have to do it. Or you are doing a walking pass. You see, when you come here for lumbar sympathectomy, you come by the side of this as TP and come and touch the bone, touch and go, and sometimes touch and go can touch this vessel there. So you have to be careful on that account. This is what I was trying to show you. The artery is coming by the side of the root. They're coming in here by the side of the root. Can you see this? And they are supplying. Can you see the vessel coming here supplying the arteries? And you put any particular material in there, patient has had it, you have had it. So you have to be careful on that account. This is what we talk safe triangle. I call it an unsafe triangle now, right? What is being talked safe is becoming unsafe for the same reason. And this is a safer triangle in here. We'll discuss because you see almost 95% or more than that, the artery, spinal artery is coming in this area, upper area, safe triangle area. And it's only 1-2% chances. When you're next to the disc, there's only 2% chance. By the way, if you look at this, only 2-3% chance. If you're behind the disc, you're not going to touch the artery anyway. Very, very low chances. And that is there. This is what we say, catastrophes. They do happen, they have happened. That's why it is known. Until unless you have a subsection angiography in your eye or on your machine. Subsection angiography with expertise, you have a subsection angiography in your eyes. What happens is, you put in a dye. If a dye is walking laterally, that means it is venous. If a dye is walking medially, understand, that means it is artery. Remember always, if dye is walking inwards, it is an artery. If dye is walking outwards, it's a vein. You're not worried if it is going venous. It happens very often. It's not unusual seeing those venous spread right there. But arterial spread is something you should be very wary of, and that shouldn't happen in here like this. This is what you have to expertise. That happens when you touch the bone. If you're not touching the bone, this is less likely to happen. Touch the bone, you may meet the artery in there. So stay retroneural. Very, very important. If your artery is coming here, going inside like this. If you're saying retroneural, you're not neither injuring the nerve nor injuring the vessel, and you're doing effective work. So retroneural, like this one. You're going in there, retroneural, your drug is going. Remember, your drug is going at the exiting route and the route above, where there's no problem. The problem is here. So I'm not very happy because it is not addressing my problem. And this is how we target. I showed you this picture earlier, how we target, and I told you about the root thing. And now this is another thing which I do very often. Campbell's triangle, put my drug in there, addresses the root, addresses the next traversing root, and that's where the problem was, right? And sometimes I do it along with the combo of the intradiscal approach. I'll show you one or two slides. Now this is where we are trying to do a Campbell's approach, go for L5, S1 root. Very often S root is involved as L5 S1 disc, which is very, very common disc problem. L4 5 L5 is the commonest ones, and it might, if it's central paracentral, it might address the S1 is the in trouble, not the L5. Very often it happens. So doing S1 block is more important than doing L5 block. Please understand. And this is doing a root block from the lamina, interlaminar spaces. Sometimes you can do a very good root spread from interlaminar spaces. That is what is lately being taught, and is more effective when there is a lot of facetal issue also involved, because you can address facet from here. You can't address facet much when you're going in there, and this can address facet much better way. I showed you this slide earlier also for the same reason. Now this is what is caudal neuroplasty is all about. We go inside caudal, put in your dye, and your Christmas tree comes beautiful. There's a block in here. You can take your Rax catheter up in there. Take your catheter up or plain catheter up, epidural catheter up in there, and do this thing. Remember, there is a septa sometime. This septa can be problematic. I'll show you in one or two slides sometime. Like this. You're putting enough volume of the drug at the caudal needle, and your drug is going all around on the one side, which is the right side, and going all out through the right side. You can see 3, 4, 5, all and S1. But you don't see a speck of dye on the other side. Because the septa, there is a membrane septa, there is giving a block. Then you go from the other side, or you puncture this side, go other side, or you see my direction is towards on the right, on the left side. Look at this midline. Still, the dye is going this way. So you just do this and go inside and put your drug in there. Now you see you have populated the other side also. In the meantime, Nagendra and Nayan, try to let the people join in, because I'm still getting messages. So what's the block? Why are you not able to join through the link? Look into that, please. Okay, this is the Rex neuroplasty typical. We go from 1 and 1.5 inch below and ½ inch away, and for the other opposite side, contralateral side, suppose a right sided problem, go from the left. If it's a left sided problem, go from the right, because you want to go across. So it's very, very important to take the catheter in there and put in ventrolateral spaces. Remember, ventrolateral space, because that's where the whole problem is. And your catheters can be bent. This can be made to bend at 1 inch from the tip, and you can put through some special needle which is called a Coda needles and all, because that doesn't injure the catheter. Otherwise, sometimes there will be catheter shearing. So you don't want that to happen. People have broken the catheter inside when they go in and out. So this is where it is very important. And this is how we do it. Go inside. If there is a problem in here, go and address the problem. Yeah, because you putting a dye may not help this root sometime, right? Or you come directly from there, or you come from the interlaminar spaces. This is all you have to learn it. And this is what we are trying to do. You're not seeing the dye nicely. You put inside and you do a breakage of adhesions. You always put hyalinase, then put in a little of LA with the steroid, or 9% of the saline, 10% of the normal saline. In India, we don't have it, so we use 3%. And that is what we are trying to break away the adhesions and open up the roots. Yes, it gives a good result, believe me. So people have made their future out of this procedure only, neuroplasties. But sometime you may say this, you're doing a caudal work and you see this picture. Now don't go ahead. I'm not happy about this. because this is a ragged posterior margin and a flat posterior margin. That means it's a fluid level, you can call it. I'm in the CSF. This is subarachnoid. What you do is you just make a AP view. You see the dye is going in the midline, focusing constant midline. It's a typical myelogram. You're seeing myelogram. You started from here, remember. Or another patient, I'm doing interlaminar work and I'm just doing epidural thing. I do this dye and this dye also. So I would not proceed unless I do it. We call it a gravity test on this thing, table tilt test or gravity test. What I'll do is I put the table head down and see where this dye is going. If this guy goes up and up and up into the dorsal in this cervical curve, that means I'm intrathecal. And then I put the head up again and see if the dye comes back. I'm intrathecal. If this dye goes up and stays there, that means it may be epidural, because thoracic curve is negative space, negative pressure in epidural space. It stays there, it won't come back. That is how you can differentiate. Then you can put your drug in there, because sometimes you have to break adhesions and all, you put your drug in there. You see, I showed you. Put a head down and it is right in the cervical curve. This is a myelogram. One of those patients who had a lumbar puncture because of the procedure part. Now, they can be, you can make an Iron Man. Beautiful Iron Man. Look at this, fixed spine. Bad problem, disc problem, but with a bad back. See this? And this is where the patient had a transition syndrome and had a very big problem. Neither surgeon nor patient wanted another surgery for this level. Right there? Obviously, when you have, spine is meant to be bent. If you fix it, then there is going to be a problem. And this is what you're trying to see. The failed back surgery syndrome. For many reasons, like post-surgical causes, we call it a recurrent or retained disc fragments, post-operative instabilities, or it was there earlier, we didn't recognize it, dural adhesions or surgical adhesions, perineural adhesions also, a root injury, obviously a direct injury with maybe a mechanical, maybe a heat injury, or acroneuritis may set in, or pseudomeningocele or something which may come up, or CSF seromas for that matter, and failure to relieve the original pathology condition. Suppose there was originally something very big, facet or synovial cyst, you didn't touch it, obviously patient will have, or post-operative wound risk infection. These are few reasons we people do have these problems. I just want to say whether I'm there on the screen, my friends. My video is on. Okay, fine. Go ahead. Put my video on, my friends.
No, sir, it's on.
Sir, you're on the screen, both your presentation as well as you.
Okay. So let's see. Now this is about the perineural adhesions we talked about. The peridural adhesions we talked about. And you see MRI trying to confirm the sensitivity is only 50%, specificity is only 70%. That is where you have to go and do your blocks and find out where exactly how much is the problem. Now this is, we keep seeing post-surgically. Now this is a patient has been operated by the best institute of India and by best surgeon, still patients in pain. Now you go sidewise and you do a kind of facet or neuroplasty or intradiscal procedure. What is required, I told you. Now this is another patient. You look at this very big, nice, good surgery done with a lumpectomy, still patients having problem. You go and do your root block in there. You should never go interlaminar in these case patients. There is going to be adhesion within dura and arachnoid, and as soon as you're trying to do epidural, you are obviously into the intrathecal space. So never ever go from here. Go either from space below or space below, or go from the sidewise, never in the midline. Please understand, people have made mistakes and they don't see the scar, don't know the history, and they go inside and they're still intrathecal straight. And we're trying to do a neuroplasty like in this patient, or you're trying to put your Rax catheter trying to break away the adhesions. Adhesions are stiff enough that they're not going, allowing you, letting you in. That is where there's a modality which I've devised. I'll show you that. And this is ultrasound is helping these days. For all those anesthesia caudals or otherwise the procedure caudal, pain caudals, you can always do with the with this plain thing. But yes, fluoro, you see the dye spread. That's more important. But if you just want to do in your open setting, you can do it without fluoro also. This is what I do is, put in a caudal needle there, put in the catheter. Now I put a guide wire first. Look at this guide wire. Put a guide wire first, let the guide wire go to the desired space. Guide wire is 0.9 mm only. Put a guide wire, over the guide wire, put in a point, this is 2 mm. The 0.9 mm guide wire, you can say 1 mm practically, and 2 mm of the catheter which goes in, and you inflate inside. And this is stricturoplasty. You can call it a epiduroplasty or stricturoplasty, neuroplasty. I do go by side of this natural window which is given by God to us, and I go in there, and because my problem is here, by the way, so I go directly in there, and this is how I do it. I'm going it transfemoral right into the area of concern, and trying to break away the adhesion or make space for the nerve. And I'm just doing the work in now. I'm doing through S1 foramina also. Look at this S1 foramina. You do S1 work there and neuroplasty. I'm doing putting a balloon there. I'm doing my work just behind L5S1 disc and doing the needful there. Although I'm doing the ozone, other things, this is long back. I've started changing my work more on the more definitive procedures. But yes, to begin with, these are very good procedures. Yes, you look at this. You can go transfronally, you can go up, you can go behind the disc, you can go below through the same guide wire. You just change the guide wire direction, put the balloon up, balloon down. You can do that. Or balloon behind the vertebral body. Very much. That's where the main problem is. Anterior epidural space procedure or surgery, I call it. I've done through caudal route. I've done through transfrontal route. I've done through the endoscope also. I've done endoscopy and I'm not happy about few things. I can put in a balloon and find out. Or through S1 foramina by the side of the endoscopy. I show you one nice good slide. If there is a migrated fragment or fragment has broken off and has gone inside, like you do a CVD stone retrieval, I put in my balloon in there and inflate the balloon there and try to pull the fragment back towards me. And once I see the part of the fragment, I just catch out the fragment and take it out. So I've done it sometime when there is a migrated fragment. And this is what balloon is doing. Look at the balloon. Inflates inside through the scope, inflates, pull the fragment and take the fragment out. You can do that. This is a very, very novel technique. And I presented some of my work in the World Spine Congress in Jeju Island. This is South Korea. This is Jeju Island, South Korea in 16. This is epidural balloon neuroplasty and foraminoplasty in innovation. I presented in the World Congress too. And this I have taken this advanced to the vertiplasty, a very bad vertiplasty with the retropulsion or posterior cortex dehiscence. And what I'm doing is I'm putting a balloon inside. What happens is when there is a bad fracture, putting balloon inside the bone also is very bad because it might retropulse the fragment further. So I hold the fragment with this balloon coming from a space or two below like this. I'm doing there's a fragment here, there's a dehiscence here. I'm inflating balloon, obviously is going to distract further on. So more injury. So what I do is I stabilize this fragment, retropulse fragment with the balloon in place and I do my intra bone work there now. And once I'm done with this, I cement this, I deflate this, and because I'm seeing it, this is a visual play now. If there is anything which is displacing my balloon, I would know there's something not good happening here. So I kind of cement this and come out. This is how I do it. I show more of this in my vertiplasty and kyphoplasty slides today or maybe another day. And this is what you're doing called caudal neuroplasty. These Koreans are very smart. They pick the idea and they put balloon over the tips here, balloon tip catheters or these small maneuvers, and they are very, very smartly doing it. Yes, you can do epiduroscopy, the visual work inside, like synovial cysts or adhesions, you can do this. I have this and I do epiduroscope sometime. This is about 2.7 mm through 3 mm needle, and you go inside. And now, unless you have a laser on you, it's not a big thing. It's only diagnostic epiduroscopy, like diagnostic tracheal view, bronchoscopy. If there is something which is to be done, you have operative work on. A laser is your operative work. I've got a small 1.2 mm, 1 mm instruments also, the forceps and baskets and other things. We'll explain maybe some later on. And this is I'm putting laser fiber in there. This is 200 micron. We have 500 micron laser fiber also. Going in there, going through one of those things and getting into the at the anterior edge and doing my work there, under visualized work. People have done SCLD procedures. I'm not very big fan of this, but yes, for synovial cysts or breaking adhesions, you can still do it. Or I do it for visualization when doing intradiscal procedure, and I want to see if there is a fragment which is taken care of. Everything is all clear. So I put a scope there. I say it's all clear. You go. That's how sometimes we do it. I told you about synovial cyst. Either you do big endoscopic work there, or you just come from the epidurally, just epiduroscopy, and just cut the wall of it. That's it, and rest all is taken care of. Whatsoever you do, what come may, you should not let this happen. This patient had a severe canal stenosis with the spastic paraplegia. She is not very old lady. Now, once questioned why didn't you get a surgery done, the answer was nobody was taking guarantee for the results. Now this is very, very bad. It's a suicidal work on their part, on the part of the patient and family. This love, I don't like this kind of love where you're harming your own patients. And now I told them you have to go for an open thing only. There's no option left with us. Yes, we have advanced pain therapies like neuromodulation, or intrathecal drug deliveries. I'll talk about neuromodulation today, little about it. And this is what gate control theory is. When the train goes, the road closes. This is the pain road, and this is the main touch and other sensation road. So this is what gate control theory was all about. People got a Nobel Prize for this. It is used for back pain, especially failed back or post-surgical syndrome or post-operative or non-operative radiculopathy. CRPS people use it. Peripheral vascular disease, it has been used. Post-herpetic neuralgias, ischemic heart disease, or vascular disease, peripheral vascular disease as explained, or agnoditis sometime. This is where you can really make use of. This is advancing. This is a new technology. It is going to catch. It's like a mobile. New mobile are going to come in. Something is going to happen. So start getting used to this technology. This is where we are trying to place our leads for upper extremity, lower back pain, or for lower extremity. There are different lead placement positions are there, and you always do a test stim first, and then you go for the final thing. And this is advanced. I told you for the other areas also. People are starting lead positioning for shoulder, for C2 area, for neck, for lower chest pain, and the butts and the thighs and foot and hand pain and other things. So you have to know the lead positionings. Now this is the first order neuron, the root stimulation DRG and the pulse RF. But the second order neuron is spinal cord stimulation and intrathecal opioid therapy. And third order neuron is right inside the brain, the motor cortex stimulation or the deep brain stimulation. This is where people are doing a lot of work at the first order neuron lately. Peripheral stimulations as well as DRG. Spinal cord stimulation is always there. There's a very good thing which is coming, is the high frequency things which is coming, which is called a paresthesia free stimulation. Now this is initially used to be a painful or paresthesia stimulation. Now paresthesia free stimulation which is going on. Yes, peripheral stimulation has come in. It is very useful. Like there's a dysgeusic patch or hepatic patch, or there's a peripheral nerve which is not getting managed, like common peroneal nerve. You can put all this, and this you can really address, and they can be very full. Painful shoulder you can put for the axillary nerve and the suprascapular nerve, and you can do a good work in there. People have done it. And this is what is called hybridization. You put a spinal cord stimulation and you do a DRG stimulation of the specific areas what you think is not been covered by the spinal cord for some reason. This is hybridization or peripheral stimulation for the matter. Now initially you put a single lead for the trial thing, and once your trial is working, you should know where the trial is. Then you put your second lead in. Some people do a 2 lead trial. It's okay, but you can do a 1 lead trial, and once you do a final placement position, always, even if you're successful is there with 1 lead, put a 2 lead, because you have a more variability and more durability of this thing, and there can be lead kind of a migration. So you have 2 leads still in there, and that is a very big help. I'm showing you one of my own patients. He came from Ethiopia. He has got 6 surgeries done from Chennai, from Thailand, from Delhi, and he doesn't want to go for 7th surgery, and n number of injections beyond surgeries. And look at this implant screw which is pressing on this nerve. Look at this, another one which is there. He used to get a very bad twisting pain in the legs. So I did a stim on this patient. I wanted this screw to go away, but the surgeon or not the patient wanted another surgery. So we went ahead. We did a placement of he's got 2 surgeries done already, by the way. So did a lead placement in there. You look at this, one laminectomy here, another laminectomy here, lower down, 2 laminectomies, and lead positioning there and onto the side of the problem. Always try to go to the side of the problem. Go across so you can do a big stim. And this is the posterior produced space. And you do staggering. You got a lead staggering. What is lead staggering is? You don't put them parallel. You see this lead staggering, one lead is here, the other lead is, the contact is not in the same level. So it's called a staggering step pattern or staggering pattern. This gives a better maneuverability and better lead kind of a stimulation, because you want stimulation from here to here or here to here. You don't want a parallel stimulation between these 2 leads, doesn't help much. So you have a more thing. This is what is lead placement. I told you he's got a nice big surgery here also, and laminectomy at D10-11 also. It was very difficult to understand one point of view. If there is a surgery here, how are you going to place your lead there in the dorsal area? Because it doesn't allow your lead to go, but still we could manage the leads there. And that is, and you have to avoid the lower surgery and the upper surgery both. And this is the lead positioning there. I have devised one nice thing. When I was to discharge this patient, let me put a scope in there, ultrasound there, and I did an ultrasound check for is there any collection or not. This beautiful implant you see in there, and then my leads are coming from here getting attached. I'm looking for any collection, seromas or hematoma or anything, and is lying nice, quiet and lovely. And patient was very happy. I couldn't recognize, once he was off pain, I couldn't recognize. He was in the lift, same lift which I was walking. Now this is important slide. In failed back surgery and spinal cord stimulations, The proposed algorithm is this. A very good slide, please. Lower back pain, tonic stimulation, go for burst. Low back pain, and back pain is BP. Back pain local, the peripheral stimulations, or if it's a diffuse pain, you go for 1 to 10K. We already call it 10K stim or 1K stim, and you can go for this. If back pain is more than leg pain, tonic double X or 1 to 10K later on. And if the leg pain is more than back pain, then you start with the tonic stimulation, tonic double X, go for burst, go for 1 to 10K. Now these are few things, these very important things, which stimulation gives best for a given patient, and you have to put your implant accordingly. Beyond the leads. The leads also sometimes are specific, the implants. About the DRG, this is a new thing, new kit, but very promising. And you see, you just go wrap the DRG in there. Look at this DRG, and this you wrap the DRG in there with the lead, and you make a strain loop in there so that it doesn't move much, and you do a thing. There are many advantages of this because the CSF volume is low. You can manage with the low battery current, and you're next to the DRG, so the migration level is low. You don't miss on the stim, and you are not doing a paresthesia which is happening in the dorsal column, and there's lesser mobility which is there. So these all put together is more favored for focal pain. We'll come to that again. Look at this DRG stuff. And by the way, DRG is the powerhouse of the segment, by the way. Remember, this is the brain of the segment, local nerve segment. So many things is going on. Nociceptive center or headquarter. This is nociceptive headquarter, you can call it. And if you address this, you don't have to go and do your need work there, by the way. So this is where you can put in a few leads in few places. People are done for even for neuropathies, for polyneuropathies also, with a very good results. And this is what we used to say. When you used to do the work with the spinal cord stimulation, you used to have a whole leg and thing pain. When the patient has a focal foot pain, with the stim, DRG stim, you can have a local foot pain. That is the advantage of the DRG. Look at this DRG versus spinal cord stimulation. It's predictable in location. It doesn't move much. There's a less variation in stimulation intensity with body position because the DRG doesn't move much with the changing in the position. Lower rate of energy consumption, obviously 1/10 almost, or maybe more, and you have a long battery. That's the battery was a big problem. Battery was very costly. So that problem is circumvented. The separation between the motor and sensory fibers are there because you're sitting on dorsal, so you only obviously have a sensory fiber coming. That's where your concern was. Motor is spared. And then map to specific dermatomes. You can go specific dermatome, check, and you can just be there. Leave all other which is not required. The patient selection is best for the hernia repair surgery, post hernia pain, total knee and hip replacement surgery, means pain for that matter, post surgical pain, foot and ankle surgery pain, or foot pain per se or ankle pain per se, which is not responding to any other treatment. Pelvic floor pain they found after surgery, and they found a good result with that. And lower extremity amputations or phantom pain or stump pain, they found this a very good thing in those ones as a special selection. Looking at this spinal cord stimulation, the failed back chronic pain, back pain, CRPS is common for both, but DRG is more helpful in the patient where there is a coccydynia. I told you those few listed things, and they found it to be a very good thing. 86% of the persistent pain relief, and reduction in the average pain is 12 months and above. This much percent patient will get this much relief. Remember, how much? This is very good. We say 50% patient will have 50% relief. 86% patient has got 81% relief. What else you look for? This is a very good bargain. And this is CRPS1 and coccydynia and lower extremities. They say dorsal root ganglion stimulation yielded higher treatment success rate for complex regional pain syndrome and coccydynia at 3 and 12 months. Beauty. Now this is say whether you want to do a dorsal root gangliectomy or reoperation or spinal cord stimulation, and they found spinal cord stimulation and spinal cord stimulation over and above, we have a DRG which is working better than the spinal cord stimulation. There are many studies now for given specific pain scenarios, focal pain scenarios. Intrathecal pumps, yes, I'm not going to detail this, but people know it. It is very good for spastic phenomena with baclofen, very good for cancer pain with the morphine and clonidine, neuropathic pain with clonidine, and ziconotide for that matter for neuropathic pain or nociceptive pain, and along with the LA and other drugs. It is still a very good modality, less utilized, but yes. What I do feel sometime, I put in those catheters, intrathecal or epidural, and tunnel them and put into the external flexometric pumps or pumps there, which can work for few months, believe me. And you don't have to really change the catheter if you've done this work well and seal them well. They rarely get infected with the good work done. That's not the case. Look, this is fluoroscopic guided cervical procedures. This is another mainstay. We are going ahead into a new domain, and it's all to do with cervical procedures. We have some time. You want to take up questions, or you want to take up the cervical procedures, my friends? You can tell me.
Sir, I think it will be better to take up questions because cervical we can do, I mean, as a separate procedure.
As a separate, I have a cervical and I have the vertebroplasty, so we can take up in the next session, and we can take up questions for today, and we leave it for the next session because very important cervical and the vertebroplasty, they are very important sessions. We can take up another day, another time. We can take up questions because we are just 2 hours.
A lot of questions are there.
Yeah.
So
So
the questions, my friend.
yeah, so there was one question about this rami communicants block or RFA. So the first is regarding use of rami communicants for dyspogenic pain. That is what is the current recommendation, current level of recommendation?
No, see, people initially started with the RMI and they found some good results, but if you can really do a sympathectomy is a better thing. RMI, there's a problem because you can have a vascular injury which is coming with a small artery just running parallel to the RMI. So people have done those injuries, so people have avoiding. By the way, RMI is not very specific because until you're sure it's a sympathetic pain, until you're sure it is sinovertebral nerve is taken care of. So RMI per se is not there, but yes, if patient keeps coming back to you with the pain, and his anterior disc is getting disease involved, there's nothing wrong in going ahead with MI along with the sympathectomy or sympathectomy itself per se. There it is okay, although it is not highly recommended these days because of the reason I explained you, because of the injuries which come by the side of it.
So what you are saying is it is falling out of favor now.
Yeah, it's falling out of favor already. It's falling out of favor already. But it's one of the modalities, so people should know about it. But yes, it's falling out of favor. Yes, true.
And sir, what about the use of RAMI RF for vertebral fracture? Let us say the patient doesn't want to undergo even vertebroplasty. In that case, with a RAMI
like the sidelines of treatment, because if there's a very straightforward, definitive, surer treatment, unless you think it can heal by itself, if you think it can be managed conservatively, can heal by itself, and you need only a temporary pain relief, then you want to do something. See, what people have done is they gone into the FACET, they did a FACET LA, and pain is taken care of. So people have done this much work also, just FACET LA, and they say pain is taken care of. Or they have done epidural and the pain is taken care of, root block at a given level, the pain is taken care of, because obviously you're taking sinovertebral nerve and the segmental root also, pain is taken care of. That is only very transient, temporary. Yes, there in those situations, because there's going to be a side fracture which is going to be carried through the RMI thing and all, there you think of taking RMI along with the other work. But RMI alone per se is not a very great technique, because this is not a sympathetic pain per se. You understand? This is more of a somatic pain which is transmitted through the main roots into the sinovertebral nerve and roots into the bone. So sometime what I am saying is there is the dorsal vertebra, there is a fracture, there is a very big pain which is not getting help relieved. I can do a focal paravertebral block or an epidural block, focal block, remember, and at the level, and even you can do a phenol work also. Pain will be taken care of. But remember, when you're doing a neurologic block, you should be always be careful. You're not doing no harm. You're doing no harm to the other structures, unintended spread, other structures. You have to be careful. Yes, you can get a very good pain relief till the healing happens. So sometimes we are advised, that okay, we want to go for conservative. There is a pain. You can do a medical management. You can do all osteoporosis and other work, which obviously has to go on along with the fracture. Especially in osteoporotic setting, you have to do it because you don't want more fractures coming out after 1 year. So those things have to go on, but yes, you have to do pain work also, and you have the medical, and you have patches coming in there, buccal patch, fentanyl patches for acute pain. Yeah, they are good. But yes, if fracture warrants, it needs a fixation, it needs stabilization, don't shy away from putting in a cement. Although more and more people are managing the fractures medically now, but if you see if the osteoporosis is there, you do your bone scans and all, and there is a severe osteoporosis, less likely these fractures heal by themselves. If it is one of those traumatic fractures, they do heal. If it is bad, collapsing. But one more important thing I want to say, because I'm going to cover in the osteoporosis and the vertebroplasty later on in my next session. But important thing is, you do not leave this patient alone. I've seen people having complication when the patient has gone home and present after month 2 or 3 with the complications on. Full collapse of the fracture, neural involvement coming up, and from a simple vertiplasty it is become a kyphoplasty. See this, when it collapses further on, now you cannot manage with a plain vertiplasty. You have to put in a balloon, open up the fracture, vertebral augmentation. Now you kind of do this, the work increases. And especially with the dorsal level, when there is a pedicles are very small, putting in a kyphon balloon through those small pedicle or parapedicular is a bigger work. So my advice is, if it's dorsal fracture, if it's one of those osteoporotic fracture, if it's likely that it is collapsing, don't wait much. Put in a vertiplasty which is smaller needle and put in a cement here and leave it alone. It doesn't harm the patient. If you know your job well, understand, if you know your job well, that's very, very important. You can persuade the patient accordingly as per your own technical skills and your own experiences. I've seen people getting better results with the cementing than otherwise, in especially osteoporotic setting, and likely to go bad to worse fractures. You have to find out those likely to go bad.
So other than the vertebral fracture, which is, the body fracture, it is also important that you consider the biomechanics and the adjacent structures which might be resulting because of the vertebral.
See, people have done studies, they have done vertiplasties. If you do overdo, especially when you try to overdo, there's a pact shifting onto the adjacent vertebra. There have been histories, there have been studies showing adjacent vertebral body fractures, because they are all osteoporotic for the matter, and you make very strong, one of them very strong, another really osteoporotic, the impact shifts to the next one and they tend to fracture the other one, next one, especially with the tribal traumas also. So this is important to understand, that once you do this cementing, one is you don't overfill, number one. Number two is you don't take it to end plate. We initially used to do end plate to end plate. And second is, always treat the osteoporosis aggressively, very aggressively, with all possible measures, with all this teriparatide and all those denosumab and other thing coming in, and the calcinate sprays, D3 biophosphonates, depending upon the bone health of the patient. This all is very, very important.
Sir,
yeah.
Though it is a very big topic, this degeneration, someone was asking if you can just brief about the management of degenerative disc.
See, it all depends. What kind of radiological finding, what is the clinical presentation part of the patient, how much is the history and timeline, what is the age of the patient, what is the patient profession, how much is the requirement on part of the patient, and what is the status. Is grade 1 is internal disc disruptions, annular tear, discus bulge out, is the secondary canal compromised, is there any root compromise, is there any chordae equina. Accordingly, it has to be managed. Initially, we start with the lower scale measures. I told you the thermal ones. When I started, I used to put in ozone and all, and now we started putting in ozone along with the RF. That is, you have to do annuloplasty for the back pain. If there is a disc is bulged and you think it's really, you are doing discography to understand if need be, and then we do ozone discography. I used to do very often. Instead of putting dye, I used to put in ozone. Ozone is irritant. If I put ozone and patient complains of pain, that means the annulus is open. Roots are there. There is inflammatory tissue which is getting irritated. So you know it. So you can treat accordingly. Now Gore and other people, what they do is, along with the dye, they put in a little steroid, because that takes care of the inflammation, and it takes spill the steroid from inside the disc outside into the epidural space where the actual problem is going on. It washes off the chemical mediators which is causing the problem onto the root, and it takes care of the modic changes also which is setting in some of these patients. But yes, we being pain specialists, we have to be careful about this, because there is one very, very big paper which says many of this disc degeneration is secondary to infections. Many of these people have been talking on the lines of that. This is a very, very big paper. Now there's a contradiction. If it is infective, low grade infection, how can we put steroid inside? Some people say it's degenerative, then obviously why should not put steroid inside? You have to calculate on those things and manage accordingly. Yes, initially I told you the thermal ones, then you go ahead with the debulking. Suppose it needs a decompression of the part. There's a high pressure disc which is kind of pushing onto the structures or causing annular tear and paining. Obviously, it's like a tire which is getting inflated into the bulging out. You reduce the tire pressure, the tire flattens back. Same thing happens in the closed disc also. So you can decompress, mechanical removal or ozone fixation. And if annulus is ruptured, I told you, then the treatment modality changes. If the fragment has gone out, obviously you have to debulk, remove from the annulus and clear the annular areas where the fragment has gone out. do annuloplasty. If the things are lying in the abdominal space and causing a compromise, neural compromise, obviously you have to decompress and debulk that fragment which is causing the problem. So this all modality is there from 1 to A to Z about the intradiscal or extradiscal, or some people are doing only epidural surgery now. They are not going intradiscal. Some people are doing interlaminar procedures. They are expertise now with interlaminar procedure. They are not doing intradiscal at all. So it all depends what exactly is the presentation on the part of the patient. But always remember, disc doesn't come all alone. Chronic disc will always have a facet component. Don't leave the facet alone. Many times people complain back pain, and that is to do with the facet pain or facetogenic pain. Please respect that part and treat facet also. All my disc procedure, when I actually go for a main procedure, I do facet on the same sitting or 1 or 2 weeks thereafter. Because there is a disc, once you handle, there is going to be some disc collapse. More the disc collapse, more is the facial loading, more is the facial pain, and patient will complain of this pain. I don't want my patient to come back and complain to me because I've done a good disc work. Why should I leave patient for the facial pain? So always treat it along with that.
Sir, one question was
there's another question about use of DRG PRF in conditions like diabetic polyneuropathy, and whether the effect of DRG PRF is the same as you would expect in DRG stimulation.
Well, DRG stimulation is PRF is one time small, and you say PRF is, some people say kind of a hoax. Yes, people are still, it's a neuromodulatory, by the way. That one is very clear. PRF is neuromodulatory, is not neurodestructive because temperature never crosses 42. Neuromodulatory. Some people claim of the PRF because easy. Put in needle, do a pulse RF, 6 minutes to 12 minutes, few segments, and you're taken care of. But if you put in a DRG stimulation, it's going to be constant there. It's constantly watching on this and doing the same part and all. People have found vascular phenomena, vascular things after this DRG stimulation. DRG stimulation. So they found it better. They have done it for polyneuropathy, I told you. Long segment they put in, or if for diabetic peripheral neuropathies or pain, they found it useful. They put in few levels of the DRG stim, and they did a study, and patients are symptomatically better, and they reduce on the medication part. That's more important. Patient medication reduce, lifestyle and functionality improves, pain skills improve. So people have done that studies because there is nothing much you can do beyond medical management. Never ever leave the medical management. Do to the fullest. Medical management is something which has to start and end with, by the way. It's not that I put a DRG, medical management goes away. Diabetes has to be well controlled. It has to be started. Don't leave it diabetes control for long, in the sense that you start late. If somebody has got diabetes, start the treatment early, because I always advocate them. There will be some patients who say, no, our diabetes is kind of corrected in between, so we leave it. No, that's not the way, because this complication rate is same. If you don't treat, they start it early. So diabetes has to be well controlled. There is a molecular theory to that. That is why these peripheral symptoms they come up, or vascular symptoms they come up, and that is where it is a help to DRG stimulation. One thing which is there is a diabetes pain, night pain especially. It is more of a ischemic pain. That's where DRG stimulation, and sometimes I do feel sympathectomies to some extent do help the pain part of it, because some pain of these peripherals, they are carried by the sympathetic fibers. So if you take the sympathetic mediated or sympathetic carried pain, so you can kind of manage those painful scenarios. That's where the DRG stimulation is better than the pulse RF alone.
Sir, one question. Somebody is asking, what is the procedure of choice for, one minute. Interventions for sciatica due to sacral chordoma.
Sacral?
Chordoma.
It's the sacral per se tumor, sacral mass you're trying to say.
The sacrococcygeal tumor, sir.
Sacral mass, sacrococcygeal, sacral masses. So if there's sciatica which is compressive, obviously you have to decompress the mass part. You can't do much about it unless it is just one of those things where there's only adhesions, or there's only one of those things which can be. If suppose it's a displaceable tumor, I would rather put in a balloon. I can put in through S1, S2, put in a balloon, open up, displace the mass away, and do my work, break away the adhesions. Or you can always do a diagnostic block to understand how far it is. You really have to understand if this is the causing problem, or this per se, like sacral mats are there. Mats themselves are painful. Or so you have to do the oncological work, you have to do the bone work also. See, you have to make the bone healthier for not it to be damaged. It's like termite, it takes away the bone, the wood which is bad, but termite free, proof, it doesn't take away. Same thing happens with the mats also. If your bones are healthier, it doesn't eat it much, and you're kind of more spared. So make a bone health, do the root work, diagnostic, and then therapeutic. Displace it if you can. If not, the tumor has to go. If it is tumor in its own right, suppose you need to shrink the tumor, there's radiotherapy. Do the radiotherapy part, chemotherapy part, surgical part, that is there. Like in ICU in bony mats, like a vertebral mats is there, and I'm doing a work. What lately I'm doing is I'm going into the bone. Now there's a mat which is lying in there. It's a mass. It's not osteoporotic thing now. So what I do is I do a bipolar or monopolar radiofrequency ablation of the tumor first. Like we do a radiotherapy ablation, we're doing a radiofrequency RF ablation of the tumor. We have such a good modality of radiofrequency ablation, monopolar or bipolar. I ablate the tumor, I put 2 needles there, put a bipolar and put a bipolar RF there, burn out the tumor. So what I've seen tumor shrinking with time, because you kind of cauterize the tumor, in other words, right there inside sitting inside the tumor. So you are very, very safe. You put your needle in the center of the tumor, ablate it, put a monopolar also. It will ablate, take it off, take it away, burn it away. But remember, when doing all this, you are not injuring the neural structures, which is important. So these are few things which you can manage from your point of view. Yes, medical management goes on, pain management goes on along with that.
Regarding
role of DRG pulse. 1 minute. Role of DRG pulse RF in painful diabetic peripheral neuropathy.
We talked this. We discussed this just a minute back.
Yeah. Sir, there is a question from Dr. Nasir, and he's talking about this tunneling of catheter which you talked about. So how long do you keep that tunneled catheter inside? What is your protocol?
The epidural or the intrathecal catheter you're talking?
Yes, sir.
Yeah, so it's a very, very useful for end of life scenario. I find it very, very useful scenario. I've had many patients who have only 2, 3, 4 months left. I put in an epidural catheter to begin with, test with that, and just find out how much is the relief. Tunnel the catheter for sure. And just bring it out, because we know it now. This is the only thing modality beyond all other things we have tried. Now this I've done intrathecal also for months together. I put intrathecal catheter also. This was available B Brown. They're the very compatible ones. You tunnel it out and take it out, and then externally use. There are kits available lately with the companies. Now Potex has got a kit where you have external pump in there. You can put a Medicaid there. It's cheaper, much cheaper than the main pumps, or the flexometric ones with the 3-way lock-in. Put a filter, always put a filter on and put a 3-way. And now what happens initially, you used to put only half or 1 hour every day, once or twice a day is good enough, because your morphine once inside intrathecal, it works for maybe 12 hours or maybe a day. So you do half an hour, 1 hour every day is more than enough, and just switch off, put a 3-way off, and disconnect the pump and leave it pump alone, and you are free. You can move around. Like there will be scenario when the disease progresses. The advantage of this pump is, when the disease progresses, you can increase your volume, increase your time, right, and duration during the daytime, or increase your concentration in the pump. It has got a drug, LA and other things, clonidine and morphine or fentanyl. You have used other drugs also combined with that, and even ketamine sometime. So if you put in there, and that takes care of the pain, you can increase the concentration over a period of time, depending on the mobility. Suppose patient is on bed ridden now, you're not worried about motor or other components. You can really increase your level to the motor level where sensory is taken care of. So those are few things which really help these patients. Very, very human job. And believe me, many of these patients, when they die, their relatives come back with the big thanks. And I have patients who themselves are very comfortable. I'm comfortable now. And they come for a refill of the pump. They're very happy for the refill. So what I do is I do 2 pump job. One pump is on the patient, and they, as soon as it is about to finish, they come with the other pump and fill the next pump, and they have a spare pump at home. Suppose the volume increases later on, they have to have the one pump finishes in 1 week time. These are 300 ml pump. You understand? So it may work for a week or maybe a month for that matter, believe me. And then patients are very, very pain free, very, very useful. Rarely infection will happen if you done your job right, tunneled it fine, and you put a sterile gauze at the outer tip of the catheter, and respected the catheter, and ask patient to respect the catheter. Sterile dressing should always be there at the catheter out port. That's very important. And even the port, where you have to injection port, it has to be put in a sterile way. I always say put a little spirit swab, kind of a dry spirit swab, dried up, and put in the same bag where there is a port, the filter is there. So it's kind of keeps the environment very sterile. And when you're injecting, use sterile syringe, wash hands, if possible put gloves. It all depends, how far they can manage. I teach them to do it. They do it every day. So we connected double filter sometime, double filter. So I've never seen infection in my patients. And another point I must mention here. Sometimes I add amikacin antibiotic in the pump itself. You're doing a smart work now. You're putting antibiotic in the pump itself. So by chance any infection which is likely there, it is taken care of by itself.
But with respect to formation of adhesions and catheter migration, it will be better to restrict the epidural catheter to a particular period of time, to a few months.
For a life expectancy which is not really much. So that's not the main worry. Main worry is the volume should keep going in the epidural space and should keep walking in. The adhesions, another problem was there when you had an intrathecal catheter with the large or high concentration morphine. They used to have a big granulomas and adhesions and other things. That was a bigger worry, so they had to reduce the concentration and really come out of the thick thoracic cord. They went away from thoracic cord. They had start putting the catheter where there was a bigger CSF volume, so that it doesn't really causes the granuloma formation. So that was a bigger worry, and there was some neurological symptom because of the granulomas on those times. Now that is taken care of. Now this catheter normally don't cause this thing. If my catheter is kind of there and is flowing, even if it is adherent, I don't mind flowing. You can always put another epidural catheter, another space, another time, and I always do epidurogram. Suppose there is some doubt of mine part, and if I'm not happy with the catheter flow, catheter is king, I do an epidurogram. You put in like put in a dye and check on the OT table, and the flow is there, and and you can kind of open up the catheter with the pressure on. But yes, what you really want is with the pump pressure, the catheter should be flowing. It should be you should be able to see. So if you can see that it is flowing, I'm not worried about the adhesions because my patients are only for a few weeks.
There was this another question about this treatment of lytic rib syndrome in cancer patients. Lytic rib because of the Mets in cancer patients.
Okay. See, if there is a lytic, you're talking bone lysis you're talking right now.
Yes.
You're talking about bone lysis. If bone lysis is there as a space to fill, you can go and fill. But first is the oncological management. Let them do their best. We are here only for palliation in these patients. Until unless somebody has got a cure, like it's multiple myeloma. There is a cure to multiple myeloma. I treat only the fractures which are bad, which are collapsing, which are symptomatic. Make them pain free. Even if cement is there, patient is cured, patient can carry on with the cement lifelong, no problem. But if it is one of those patients who is not going to stay for lifelong or has got a expectancy which is not in years, and you think it's one of those things, you try to manage. See, there have been times like osteoid osteoma. I've treated. I showed you in the dorsal area. Keep seeing those osteomas in many places. I put my needle in there and do my RF work. That's it. Pain goes away. Do my RF, and my RF is taken care. That's all is required inside osteolytic lesion radiofrequency. Very good modality of treatment because kills the nerves off, induces fibrosis, heat injury is there, that is there. But if this is in the bone mass, vertebral bone mass, and you think it's worrying and it may collapse or it is collapsing, and this is the time you go and put in a augmentation, put in a little cement and help those. There's no harm in doing that, but you should not be spilling the things. That's the only thing.
But if it were to involve the ribs?
Yeah, obviously not. You're not going to do in the ribs and peripheries. You're not done. I've done in few cases. There was a pubic ramus fracture. So and the patient had a sacral fracture. She had a fall. The sacral, so it's a ring fracture on part of the thing. Sacrum was fractured, sacroplasty. The vertebra, one of the vertebrae was fractured. I did cementing. Now there is a fracture on. She actually fractured twice. She fractured one time and she went to the lot of walking in the garden. See, imagine the patient was pain free. She started doing lot of walking and she fractured the other side. She was severely osteoporotic. She fractured the other pubic ramus. I'm talking this time. I'm talking pubic ramus, and the ring is gone. So obviously she was not able to sit and walk even. So and there's nothing much. The pubic bone is too thin. Now this time we're doing encasting the pubic ramus. So I've done that in few patients. and casting means one or two patients and cast over it above, but it's not advisable. Best would be the plate. If surgeons are there and they wanted to go ahead and do it, plate. But again, the problem is with the osteoporotic thing, the plate even doesn't stay. Medical management, conservative management, rest, physio, osteoporosis management is the best thing. If you are pushed or for some reason by patient or relatives or by yourself you think is going to help the patient and you want to do something there, you can go inside, put it either inside or outside. But I don't advocate outside. I'm just saying it for the sake of saying it, but not advocate it outside. Do rib fractures? No, rib fractures is beautiful treatment. You do the rib work, whatever is required. Rib really heals very, very well. You just have to do is the pain work. If it is osteolytic lesion, go inside the lesion, do RF. Do RF the intercostal nerves, level and above. See what nerves are involved, or paravertebral block, which I told you is a very, very effective block. Don't miss on this. Pain is taken care of. Now rest comes is what to do next. There have been instances people come with the fractures and you have to manage. You take the pain part and rib will heal by itself. But treat osteoporosis for sure. That's the important thing.
So what about the thoracic intrathecal neurolysis? Have you ever tried?
Yeah. No, I am very big fan of it. Not just tried. I'm very, very big fan of it. See, anything to do with the torso and it's a bad pain, either malignant or non-malignant or intractable pain, which is not getting help with any modality we have tried. All modalities you have tried. But in cancer, I don't wait long. I told you. I start from the periphery. Suppose CA lung is there. I start from the intercostal, go proximal, go paravertebral, go proximal, go epidural, go proximal, go intrathecal. That's how I timeline my thing, depending on how much time is left to the patient and how much is my patience, by the way. That is how you keep going more proximally. But start with the periphery, if periphery is working better. Now when you go proximal, intrathecal is beautiful modality. Learn it. I think all pain specialists should be well versed with this technology and they should be well trained, because this has got a very great pain relief in those dying patients or end of life care patients without any harm. That's the worst part, the best part, without any harm. In the sense, if you did your procedure right, there's no harm, only sensory loss is there on the segment of what you involved. Remember, any part, any neurolysis you do in the body, remember everybody has to understand, any neurolysis you do in the body, when you do this neurolysis, always tell the patient this part is getting now numb. Take care, respect this part, like laticular nerve thigh. If you are not told, you did a neurolysis, you didn't tell the patient will burn thigh without knowing. Same happens with the intercostal also. I have had a patient whom did intercostal, then paravertebral, then intrathecal, and patient came back with the big burn, bone exposing burn on the back. Now what is this? Because she was putting a pad, heating pad, sometime, because you have anesthesia dolorosa sometime coming in. Understand, this is the important thing. Now she was kind of putting pad and she forgot on the night and she burned through and through. Can you imagine somebody who burns through and through onto the bone is not having pain of the burn? That means it is anesthesia dolorosa. It's not in the peripheral pain. Please everybody understand this point. It's anesthesia dolorosa now. So she central pain syndrome. So she kind of burned the thing. So this is something has to be told to everybody. Now coming back to the point, when there is an intercostal, the intrathecal neurolysis, when you on the side, what I do is I prefer alcohol. Now I tell you why. I go intrathecal space where there is a dermatome which is involved. I take that, like there are 3 dermatomes. I take the central dermatome now, which is involved of the 3, and what I do is in the central dermatome I put my needle LP onto the side of the lesion. Remember, if it's left side of the lesion, I have put my needle towards the left side of the vertebra, and it's like this. Here, I'll just show you, depict this. Like if this is there, I'm going towards on the side of the lesion. If this side is the lesion, I'm putting on the side of the lesion here, right? And once I'm intrathecal, you know the CSF, in the dorsal, remember, thoracic cord is thick. CSF, you really have to be very patient to see the CSF drop. Or sometimes you take a tuberculin syringe and maybe aspirate. Don't aspirate with 2 ml 5 ml syringe. As soon as you aspirate, the neural structure comes in and you don't see it. So you have to patiently aspirate it for CSF, and only a drop or 2 is enough to understand your CSF. Right? And once you're inside the area, now you make the patient tilt sidewise. It's by the way sidewise only, sidewise this way, and make it a semi supine like this, right? This, and now this is your what do you call the like this one, like, because you don't want to make it. This is what dependent when you use phenol. When you're using alcohol, you want to make it float up. So alcohol will go in there. Now you're putting in there, you put 0.1, 0.2 ml alcohol at one point of time onto the side of the lesion in the lateral position, and sometimes you put in a wedge here. You wedge on the in the patient. So this becomes the superior most. This area becomes superior most. Suppose it is D6. I put a wedge in there D6, so it is bent like this. So it is the D6 is gone up, more up. So as soon as I put my alcohol in there, it is floating up. It is not spilling onto the other side. So ultimately, what is happening is the cone is becoming like this, and you're putting in your, this is the area of concern, and you're putting your alcohol in the semi supine position, semi prone position. So semi prone position. Now this time easy. I'll show you the picture. Semi prone position. Now what you do is you're putting alcohol. It is floating onto the next to the DRG, and you put 0.1, 0.2 ml at a time. Don't put more than that. 0.1, 0.2. If you put it with the insulin syringe, if you take it more, take 1 ml at a time. Obviously, it doesn't take you much in the insulin syringe. 0.1 ml at a time. Give it slow injection over a few seconds, 5-10 seconds. Wait for another 10, 15, 20 seconds, half minute. Then put another 0.1 ml with that 5-10 seconds time. Because once you're trying to put drug inside, it is walking off the needle. It is not going as a jet. It is going and it is walking, floating up. So that's why you give it very slow. If you go it, there's a cord here. If you give a jet, it'll tie the cord, and you have a long track injury gone. Bladder ball involvement will be there. So we give it a very slow. It walks up into towards the DRG. Now it floats, fills the DRG only, and then if you want 2 or 3 levels now, you want it 1 level above. You may put in the middle level now, and you want this and this level to go. What you do is, if I want to go the other level, I make it head up or the level up where you want it to go. Or if you want to go the other way around, you make it other level one, and you start putting more drug. Same way. Now what is happening is it will walk inside the intrathecal space towards the other gutter. Other 1 level above, 1 level below. But remember, if you put too much volume, it will walk 2, 3, 4 segments above, 2, 3, 4 segments below. So you using on an average 0.5 to 1 ml at each gutter, each level. So if there are 2 or 3 levels involved, so accordingly you add your volumes and remember. But once you're putting the up and below, it may keep walking up. You have to be very, very careful. It is going so slow that from here it is just coming there. It's not going further on. You don't want it to go next level, because after all it's a neurolysis. Alcohol, absolute neurolysis is going on. So, and is very, very effective. I told you, it's very, very. I have had a patient who had a CA lung. I was doing this procedure on the patient, and patient says it won't affect my arm. I said, why? It is ever? Well, no. Then why are you asking me? Because I drive back home. So what he was doing is, he had a CA lung. He used to come and get my injection done, intrathecal neurolysis, and he used to drive back home himself. The patient should be full of life. The whole idea is, these are patients, they know the disease, they know how much is there, but you want to give them quality in a given day's time. If you manage the pain is very bad. I've had a patient who has CA lung. I did an intrathecal neurolysis. You know, when he went to the ward, he gave me a video testimonial. Okay, doctor, get my CT scan done. I said, what has happened? He says, my cancer is cured. If you take care of the pain, for them, pain means cancer, cancer means pain. If the pain is gone, they feel their cancer is taken care of. So that is the beauty of your procedure, your work in these kind of patients. You give them life back, and they are kind of pain free. That's what the whole intent in palliative care. You give them pain free death, pain free life, and pain free death. That's what the whole idea is all about.
I think, sir, we should conclude here. Enough. I think what I know, you will never be tired. We will be tired. I have seen in 2012 was the whole day from the morning OPD till evening 9 o'clock.
8 days, 12 hours every day.
Evening 9 o'clock from OPD, then all discussion, then all so many cases that time you gathered. So we are getting tired. Wearing that laid gown. Most important.
Thanks slide. I'll put a thanks slides on, and then we can conclude this day. People can conclude. You can conclude. And just 1 or 2 slides, by the way. And second is we have a very, very important session on the neck pain, cervical issues, cervical facet, cervical disc, cervical nerve pains, and all those things. Myofascial facet. Then the vertiplasty, the mainstay vertiplasty, kyphoplasty. I knew it. I won't be able to finish. I knew it for sure. Although we extended time, but I knew I won't be able to finish because I wanted to give time to each slide. I wanted to teach and educate, not rush through the slide. That's why it took a little longer.
But I will prefer you keep hypoplasty, kyphoplasty only one day. Don't mix up with other things. So make it for 1 hour. Make it for
neck pain also, very, very important thing. The neck pain. So I don't know. People have to come another day for neck pain in that case. What I'll try to do is combine. It will be about 1.5 hour session on the neck and the vertebroplasty kyphoplasty. We can combine these two modalities. They are advanced techniques, by the way, for all people who are doing pain work and all. So I'll just share 1 or 2 slides at the end of it, and then we can conclude. I'll just say thanks, with these slides. Just let me see, where do I? Okay, this was cervical thing. Okay, this was cervical thing. We're going to talk about all this in the next time. Balloon neuroplasty in the cervical area, cervical facets. We're going to talk. The ultrasound has got a lot of things to do. C1, C2 blocks, very important C1, C2 things, upper cervical areas. We're going to talk all this next time. We have this is what we're saying. Yeah, Ashish, we want alcohol to float up.
Yeah. Exactly. This is the image I wanted to see, sir.
Yeah, this is this slide is already there because we didn't talk this, and this is when you use phenol, which is very cumbersome, very difficult position. You can't come from below and put in alcohol, phenol from there. So alcohol you can always do it from here. I've got a very good slide. This one earlier was there. Probably I missed on that. So this is the cervical thing, cervical disc procedures. We will talk all this next time. Cervical disc effects. We're going to talk this. Not many people are doing cervical vertebroplasties. This is the main vertebroplasty slides. We'll talk all this later on. We have few good work there to share. We will talk this for sure. This is my balloon work there along with the kypho vertebro, and this is it. And this is the second. This is one of the sessions which we do. And I say the best way to define your future is to design it, and let's design it designer's way. That's what it is. This is one of the workshop scenarios, where people are here. My friend Dr. Shantanu is here, right here, and other friends would be around. Ashish, I will look for your photos also. And this is it. And this is thanks to my family for sparing me to give time to my friends and to do a little of teaching. Both the sons are in Canada right now. They're in Toronto. Any questions? We have gone through question session, and thanks for your time, my friends. Thanks for your time.
Thank you, sir. It's great.
Thank you, sir.
Yeah. So I'm just stop sharing my screen.
Yes, sir.
Yeah. So my friends, all of you, thanks for your time. You really spared this long 3 hours practically almost. And Dr. Shantanu, thank you very much, my dear Ashish.
Thank you, sir. Pleasure was all ours.
Taking load of these questions and the big session, So it's something you need talented people like you to carry the whole thing further on. Thank you so much. We'll take up all this, the cervical and the vertebroplasty.
Sure, sir. We'll again plan it.
Yeah, it's okay. We can plan down the line. Talk
because many are requesting for the recording, as this is a Sunday. Many didn't attend and all. They wrote a mail.
I know there are so many resistants. Not many which were there during because the parallel talks going on other places, ultrasound and all. But it's part of the whole thing. But I'm very happy with the people. See, my duty is to educate as many as I can because I'm already on. So this is at their end how much they can grasp and take home message. Today I was a little slow for the same reason because I wanted them to have more carry home messages. And there's so much of carry home, and Ashish and Shantanu would understand what I'm talking. Others would understand it down the line when they do all this practically, they would understand what I mean. So thanks for your time, my friends. Right? So bye for the day, and be corona safe, be healthy, stay healthy, and do a pain-free work for all your patients. So sweet. Thank you very much. Thank you, friends.
Thank you.
Bye-bye.